Dr. Miller, a couple stellar residents who helped me with my talk, Richard Thomas and Brian Leo. A lot of stuff is I've referenced the Orthopedic Basic Science textbook. A lot of information comes from there, and again, that's what the Academy wants you to know. And test questions from several OIT exams and self-assessment exams to give you an idea of what topics and how much detail you're expected to know the topics in for the basic science section. Just to lose a few points right now, these are my loyalties. I may lose some credibility, but I believe the Redskins will win the Super Bowl this year, and the Cavs are going to finish in the top 10. Those are my predictions. I'm going to do the first part of basic science, which is section 1, 3, and 8 in the textbook, bone, neuromuscular and connective tissues, and biomechanics and biomaterials. By far the worst topic is the last one. My partner at UVA, Dr. Foster, is going to speak on the remainder of the chapters tomorrow afternoon. Obviously, this is not an ideal topic. It is, again, very painful, but I'll try to keep it as entertaining as possible and try to keep you out of a coma during the next 3 hours. In Miller, we trust, right? It's hard to believe we actually trust this guy if you see him walking around the University of Virginia dressed up like that. He's required to wear a cool suit because he sweats too much in the OR. This is true in real life. Imagination is more important than knowledge. Unfortunately, for the basic science section, you have to know the stuff, and you can't imagine the answers. You can get out of jams in the OR by coming up with inventive ideas, but unfortunately not for this part. So fasten your seatbelts. We're going to really fly through a lot of material here, and it's all in the syllabus. So if you feel like you're behind, just follow in the syllabus. So we'll start with bone. Overview: histology of bone, bone injury and repair, conditions of bone mineralization, bone density, and bone viability. It's a lot of material, but a lot of test questions come from this. This is going to be a review for many of you. If there's any basic scientists in the room, you probably know all this. But types of bone, two types, lamellar and woven. Lamellar bone is broken into cortical bone and cancellous bone, and woven bone is seen in pathologic states during fracture healing and tumors, but it's divided into immature and, again, pathologic bone. Example of a histological slide. On your left, the woven bone, you'll notice that it's hypercellular. It's not as well organized as the lamellar bone, which is on your right. Lamellar bone is, again, more organized, there's less cellularity, and it's stress-oriented. Wolff's Law comes up several times, and I know most of you are familiar with it, but bone remodels according to stress, and that's important to know. Cortical bone, now lamellar bone is divided into cortical bone and cancellous bone. Cortical bone comprises 80% of the skeleton, a very slow turnover rate. It's composed of osteons, which is the functional unit of bone. It has a very high Young's modulus, which is the modulus of elasticity, measuring stiffness, and we'll talk about that more in the biomechanics section. There's a high resistance to torsion and bending. The osteon, again, or the Haversian system, is the functional unit of bone. Most of you are familiar with this. It's comprised of Volkmann's canals in which vessels run through to provide nutrients. There's interstitial lamellae, which is the matrix between the osteons. Cement lines are the divisions between the osteolines. And there's canaliculi, which are communications between the osteocytes, which are the main cells within the osteon. And this is just a diagram showing that, and it's in your handout if you need more information. Cancellous bone, less dense than cortical bone. There's a high turnover rate. It's more elastic than cortical bone, but it's less stiff, so it has a smaller Young's modulus of elasticity. The other type of bone is woven bone. It's immature. It's immature bone, and it's seen in fracture callus or pathologic conditions such as infection, malignancy, and stress reactions. It's weak compared to lamellar bone. It has a random organization, has increased turnover, it's not stress-oriented, and it's hypercellular. Moving on to cellular biology of bone, there's 4 types of cells that make up bone: osteoblasts, osteocytes, osteoclasts, and osteoprogenitor cells. Osteoblasts are the bone-forming cells. They're derived from undifferentiated mesenchymal cells, and they synthesize type 1 collagen. This has been a test question on several OIT exams. Know that. It has high alkaline phosphatase activity, and you can measure that to get an idea if you have a bone-forming pathologic condition. This slide is a little busy, but the main osteoblast receptor to know is the receptor for parathyroid hormone. Parathyroid hormone is involved in calcium hemostasis. homeostasis. And the osteoblast, when PTH binds an osteoblast receptor, it releases a secondary messenger that stimulates osteoclast activity. This has been on the exam several times. Osteoclasts do not have a receptor for PTH. They are stimulated by a secondary messenger from interaction with osteoblasts. The other receptors are listed and for your information, but they rarely test those receptors. Here's an EM photograph of osteoblasts. You can see osteoblasts lining up to form bone. The other type of cell is osteocytes. They're 90% of the cells in the mature skeleton. They're former osteoblasts trapped in new matrix. So when an osteoblast lays down bone and bone matrix, it becomes surrounded with this matrix and eventually becomes an osteocyte. The function of the osteocyte is to maintain bone. It's involved with controlling extracellular concentrations of calcium and phosphorus, and it's directly stimulated by calcitonin and inhibited by PTH. So osteocytes are really the only cell that has a receptor for calcitonin and PTH compared to osteoblasts and osteoclasts. EM of an osteocyte, and you can see the cell surrounded by matrix. The third type of cell is an osteoclast. It resorbs bone. It's a multinucleated, irregular-shaped giant cell which originates from monocytes. It has a ruffled border which increases the surface area for resorption, and this area of resorption is House-Schiff's lacunae. I know this is a review for many of you, but again, it's important to know these definitions because they can get you the right answer on the exam. The osteoclast, one thing to know is that bone formation and resorption is coupled. It's always a coupled process, and we'll talk a little bit more on that in the osteoporosis section of this talk. But osteoclasts synthesize tartrate-resistant acid phosphatase, which breaks down the mineral portion of it and exposes the osteoid for breakdown. It binds to bone surface via anchoring proteins called integrins. That may pop up, although I don't think it will, just so you're familiar with the name. Osteoclasts possess specific receptors for calcitonin, which inhibit bone resorption. They're responsible for bone resorption in multiple myeloma and metastatic bone disease, and in IL-1 is a potent stimulator for osteoclastic bone resorption, and it's been found in recent basic science research surrounding loose total joint arthroplasties. Here's an osteoclast, EM of that, and you can see the red area shows House-Schiff's lacunae. You see that it's a multinucleated cell. The last cell type is osteoprogenitor cells. They're precursors to osteoblasts. They're mesenchymal cells which line the Haversian system, and they differentiate after they're stimulated by appropriate growth factors, and we'll talk a little bit more about that. Now, bone matrix is composed of two components. The organic component is 40%, and the inorganic component is 60%. The organic components are listed. Collagen is the main one, and the one you'll likely be tested on. There's also proteoglycans, non-collagenous matrix proteins, growth factors, and cytokines. Collagen is the tensile strength of bone. It's type 1 collagen again. Bone has the word 1 in it, so that's just one way to remember type 1 collagen. Collagen, of course, is triple helix, alpha-1 and alpha-2 chains, which form a fibril. Mineral deposition occurs in the pores and hole zones of the collagen, and that, for some reason, has come up on a test before as well. Cross-linking decreases solubility and increases tensile strength. Just a slide showing that you get sequential deposition of mineral within the pores and holes of the collagen fibrils. There's an EM of bone collagen. You can see the highly organized structure, and obviously that provides the tensile strength of bone. Proteoglycans are the next organic component. They provide compressive strength of bone, and they're composed of glycoaminoglycan and protein complexes. And I think Dr. Foster will talk a little bit more about that for you. The matrix proteins that you will come across promote mineralization and bone formation. The main one to know is osteocalcin, or bone glob protein. Osteonectin and osteopontin are less frequently asked questions. Osteocalcin is produced by osteoblasts, and it's the most abundant non-collagenous matrix protein in bone. It attracts osteoclasts. It regulates bone density. A lot of these proteins we don't have a full understanding of. The main thing to know about osteocalcin is the most abundant matrix protein It's inhibited by PTH, stimulated by vitamin D. All these are characteristics. You're not going to be asked that much detail on these proteins, and I'll give you a better idea of what type of level of detail you need to know in the questions. Again, osteonectin secreted by platelets and osteoblasts, and it's involved with matrix mineralization. Osteopontin is just a cell-binding protein. Several cytokines and growth factors are part of the organic component of bone. They're very present in small amounts, and they're involved in cell differentiation, activation, growth, turnover. It's just several roles that we still don't have a full understanding about, and it's rare to get asked a question on these currently on exam. The inorganic component is the majority of the dry weight of bone, and it's calcium hydroxyapatite. It provides also compressive strength of bone with the proteoglycan component. Know the formula for hydroxyapatite. That's come up before as well. Bone remodeling is modulated by systemic hormones and local hormones. It's affected by stress. Again, Wolff's Law. There's another question that I actually missed on my OITE as a chief, the Hutter-Volkmann Law. So I'm not sure how many of you are familiar with this, but it is a game for a question. It's mechanical factors influence longitudinal growth, bone remodeling, and fracture repair. Compression inhibits growth, tension stimulates growth. There's some application of this law in pediatric orthopedics for situations such as Blount's disease. Bone remodeling. Cortical bone remodels in the following sequence. You get osteoclastic tunneling by these cutting cones, is depicted there. Following the osteoclastic tunneling, you get capillaries, ingrowth, which brings osteoblasts, and you get new bone formation or remodeling. You can see at the tip of that picture there's the multinucleated cells, which are the osteoclasts. A few points on bone circulation. 5 to 10% of cardiac output. In situations where you have a high rate of bone turnover formation, such as Paget's disease, you can have problems with high output cardiac failure. But a majority of bone is just 5 to 10% of cardiac output in a normal situation. There's 3 sources to the long bone: the nutrient artery system, metaphyseal-epiphyseal system, and periosteal system. You can see by this that the bone is a very vascular structure, and obviously that has implications when bone is injured in fracture. The nutrient artery system originates from major arteries. It enters the diaphysis through the nutrient foramen and into the medullary canal. It supplies 2/3 of the cortex. Okay? It's in a high-pressure system. So obviously, if you're reaming a femur, you're disrupting a significant amount of the nutrient artery system. Fortunately, despite that, and losing a portion of the inner arterial system, there's other circulation to the bone. One is the metaphyseal-epiphyseal system, which is involved in growth plate development. And then you have the periosteal system, which is primarily capillaries, low pressure, and it supplies the outer 1/3 of the diaphyseal cortex. Blood flow in fracture healing. Obviously, it's important for fracture healing. The initial response is decreased flow at the time of injury. Then it increases within hours and peaks at 2 weeks. This has been a question, I think, 2 years ago on the OITE. So the peak is at 2 weeks, and it returns to normal 3 to 5 months later. It's the major determinant of fracture healing. If you don't have appropriate blood supply, you end up getting situations of non-union. Tissue surrounding bone. Everyone's familiar with periosteum. It's a very tough connective tissue surrounding the bone. It's highly developed in children. That's why we can get away with reducing both bone forearms in children and not requiring a stable fixation, because there's a nice periosteal sleeve that helps maintain your reduction, provides stability, and also enhances healing, because the periosteum has an inner cambium layer where there's osteoblastic progenitor cells. And this is the periosteum is important in healing fractures, as well as it's responsible for appositional growth of the bone, and that's essentially bone diameter, and it's important in periosteal callus and fracture healing. The only things you need to know about the bone marrow are there's a source of osteoprogenitor cells. There's 2 types of marrow, red marrow and yellow marrow. Red marrow is what all of you have, hematopoietic. It's 40% water, 40% fat, 20% protein. Yellow marrow is what Dr. Miller has, inactive, aged. So it's 15% water, 80% fat, 5% protein. again, I don't know if, just take a little break here. I don't know how many of you have gotten to know Dr. Miller over the years. Probably none, but he's a very interesting guy. Everything needs to be done 2 days ago. He's got a lot of high-pressure speech. He's very uptight all the time. And I don't know, this may be a reason. I have no idea where that tube's going. But this is him in the OR, and that's his cool suit pose. But I have no idea where that is. But that may be a reason why he's the way he is. Types of bone formation: endochondral, intramembranous, and appositional. Again, this is a review for everyone. Endochondral bone formation. Bone replaces a cartilage model. Cartilage is not converted to bone. That is a misconception. Okay. Examples are embryonic long bone formation at the growth plate, longitudinal growth at the physis, fracture callus, and this has come up on a test before, a DMB matrix enhanced bone formation. Briefly, rarely get asked about embryonic long bone, but there's an onlodge at 6 weeks in utero. Vascular buds invade this mesenchymal model and bring osteoprogenitor cells, which create the primary centers of ossification at 8 weeks. Okay, and secondary centers develop after that, and cartilage model grows by apposition, and then bone, again, replaces the cartilage model. Just some pictures of the onlodge and vascular infiltration of an embryonic bone. Okay, physis. I'm sure everyone's read the article by Brighton that describes the physis, so it will be a review for many of you, but it's a favorite question of the OITE and the self-assessment exams, and will likely be on your boards. There's two types of the physis: the horizontal growth plate, the spherical growth plate. Both have the same arrangement. They're divided into zones. Everyone remembers these zones, right? Reserve, proliferative, hypertrophic, metaphysis. This is fair game for questions. The hypertrophic zone is divided into three: zone of maturation, zone of degeneration, and zone of provisional calcification. Reserve zone. The few things you need to know about each zone. It's where matrix production occurs. That's why it's called the reserve zone. So cells store lipids, glycogen, and proteoglycan for later growth. There's low oxygen tension, and it's essentially an anabolic portion of the growth plate. The proliferative zone is where the actual longitudinal growth occurs. The chondrocytes are arranged in columns. The top cell is the dividing one, and increased oxygen tension inhibits calcification. So this zone, the main thing is as it's named. It's cellular proliferation and matrix production. The hypertrophic zone is divided again into three zones: maturation, degeneration, and provisional calcification. Cells increase in size, accumulate calcium, and then they die, and then osteoblasts come in and use the scaffold to make bone. This is just for your information. It's rare that they ask something of this detail about what happens in each of the zones. So just peruse that, but don't put it in any significant memory bank. The metaphysis is adjacent to the physis. The osteoblasts use the scaffold. You get primary spongiosa first, and that's remodeled to form secondary spongiosa. The cortical bone, again, remodels in response to stress. Periphery of the physis, you have two terms you need to know: the groove of Ranvier. It supplies chondrocytes to the periphery of the growth plate for appositional growth, as we mentioned. And the perichondrial ring of Lacroix is a dense fibrous tissue that anchors and supports the physis. When you get type 1 physeal injuries, you may have disruption of this portion of the periosteum. Hormones and growth factors are involved in the physis, and again, it's rare to have to answer a question this, but this chart is for your information as well. And it's, again, don't memorize this, just to give you an idea of the fact that you have local factors and systemic endocrine factors that are involved in the different layers of the growth plate. So it's a very complex system. Physeal abnormalities. I think this will probably be covered by Dr. Foster in some of his lectures, but reserve zone, this is just you have to memorize. There's no way around this. You have to memorize that these are the abnormalities are seen at each of these zones. The one that has come up several times on the OITE and self-assessment exam is that rickets, there's an abnormality at the hypertrophic zone for rickets, and for physeal fractures occur through the zone of provisional calcification. Can everyone read that? I didn't show my wife this because I think she'd get upset. Can you guys read it? For those of you who are single, you might want to heed this. All right, next type of bone, intramembranous ossification. It occurs without a cartilage model. You get undifferentiated mesenchymal cells, which aggregate into layers and differentiate into osteoblasts. And the osteoblasts deposit organic matrix, which is subsequently mineralized to bone. And this is seen in embryonic flat bone formation, the pelvis, clavicle, and skull, and in cases of distraction osteogenesis. That's come up on the exam as well. What type of bone do you see in limb lengthening procedures with the Elizaroff? And that's intramembranous ossification. Appositional ossification, the osteoblasts align on existing bone surfaces and lay down new bone. And that's from the periosteum, the inner cambium layer. And it's also seen in a bone remodeling of that portion in the secondary spongiosa. Does anyone know who this is? All right. So how did his career end? Lawrence Taylor, right? Open tibia fracture, Monday night game against the New York Giants. So that leads us to fracture repair. Bone injury and repair. So the fracture repair is a continuum of events. You get these stages you have to know: inflammation, soft callus formation, hard callus formation, and remodeling. In inflammation, you get bleeding at the fracture site and a hematoma. The hematoma is the source of hematopoietic cells and growth factors. And fibroblasts, mesenchymal cells, and osteoprogenitor cells migrate to this site initially to form granulation tissue, and that's the first step of fracture healing. You get primary callus repair at about 2 weeks. This is soft callus, and this is converted to hard callus by endochondral ossification. There's also a medullary callus formed within the medullary canal, but that's at a much slower rate than the periosteal callus that's converted by endochondral ossification. Now, this is a key point. The amount of callus formation is indirectly proportional to the amount of immobilization of the fracture. Primary cortical healing, which you get when you plate a both bone forearm fracture, resembles normal remodeling, so you don't get visible callus. You get sort of a osteoclast cutting cone, and you get healing through that primary cortical healing or remodeling phenomena. So there's the difference between a very rigidly fixed fracture and one that's not as rigidly fixed. You have to know this chart. Cast fixation or cast immobilization results in periosteal bridging callus, and that is endochondral ossification for healing. Compression plating is primary bone healing, and it's a cutting cone phenomena. Intramedullary nail, you have a periosteal callus, and that's endochondral ossification. External fixation depends on how rigid your fixation is. If it's less rigid, you have motion at the fracture site, you'll get a big wad of callus. You've all seen that. You get periosteal callus formation. If it's more rigid, you get primary bone healing. Inadequate fixation results in hypertrophic non-unions, and that is failed endochondral ossification. And what happens is, remember, in endochondral ossification, you have cartilage first and then bone. So type 2 collagen occurs first. And in a hypertrophic non-union, you end up getting predominant type 2 collagen, and that's what's, eventually you can get a pseudoarthrosis at some fracture non-union sites, and so it's predominantly type 2 collagen. Remodeling starts at 2 weeks, and for some reason they asked this question 2 years ago: when does remodeling end? And the answer was 7 years. I don't know why they wanted that answer, but it continues well after the fracture heals, so it's a long process. Again, it assumes normal shape based on stress. Woven bone is replaced with lamellar bone, and fracture healing is complete with repopulation of the marrow space. Biochemistry of fracture healing, they like to ask what types of collagen are present during different stages. So initially you get a whole mess of collagen, type 1, 2, 3, and 5. Then you get, in the endochondral ossification, type 2 predominates. And then when you get the transition from chondroid to osteoid, you have 1 and 2 present, and also type 10, which is involved in calcification in the primary spongiosa, or, well, that's more in the growth plate, but type 10 is important in the mineralization portion of the fracture healing. And then when you have a healed fracture, it's mainly collagen type 1. Growth factors involved in fracture healing. These will pop up on the exam. I think we've heard about them long enough that now they're game for testing. So BMP is osteoinductive. It causes mesenchymal cell differentiation to osteoclasts. The target cell for BMP is undifferentiated perivascular mesenchymal cells. Transforming growth factor beta induces mesenchymal cells to produce type 2 collagen proteoglycans. Type 2 collagen is involved in early fracture healing, right? The early callus formation. So that's one of the roles of transforming growth factor beta that we're trying to manipulate, is to figure out how we can initiate fracture healing, since it's so important in the early stages. Insulin-like growth factor stimulates type 1 collagen. It's an anabolic. It's cellular proliferation, cartilage matrix synthesis. Again, has a role in fracture healing. Platelet-derived growth factor released from platelets on the initial hematoma inflammation stage. It's chemotactic and attracts inflammatory cells to the fracture site. Moving on to bone grafting. Graft properties, important properties that you need to know these different definitions. An osteoconductive matrix is a scaffold or framework in which bone growth occurs on. You have osteoinductive factors such as BMP and transforming growth factor beta, which promote bone formation that we just talked about. Some grafts have osteogenic cells present in them, and that is actually the osteoprogenitor cells and the bone-forming cells. And again, you have to look at graft properties to see what grafts provide structural integrity. Two types of grafts, autografts and allografts. This should all be a review. Allografts there's several types. There's fresh allografts, which are rarely used. They have very high antigenicity and can be rejected. Fresh frozen are less immunogenic and have BMP preserved. Freeze-dried, you don't have any more structural integrity and depletes BMP, but they're the least immunogenic and they're essentially osteoconductive. Demineralized bone matrix is osteoconductive and osteoinductive. Bone marrow cells, and this is a routine question, incite the greatest immunogenic response compared to other constituents. The least immunogenic response is the actual mineral, or hydroxyapatite. So what are your bone grafting choices? Cortical, cancellous, osteochondral, and vascularized bone grafts. Cortical bone graft properties, slow incorporation. It provides structural support, and remodeling occurs via resorption followed by deposition of new bone. It's a very slow process, but if you're resorbing your bone graft, obviously it can be weak, and then it can be prone to fatigue fractures. So when you put a fibular graft in, or if you do a vascularized grafting is a little bit different, but if you do a fibular graft, there's a period of resorption, and that's when you get your fatigue fracture. Cancellous bone is a different, it's incorporated differently, it's revascularized quickly, and osteoblasts lay down new bone on old trabeculi. This is termed creeping substitution. This is a favorite basic science question in the boards. What's the process involved with incorporation of cancellous bone graft? It's creeping substitution. The synthetic bone grafts, calcium, silicone, and aluminum, the one key thing to get, despite what you use, all of these are osteoconductive. None of them are osteoinductive. They provide a scaffold for bone growth. Unfortunately, this table did not come out on your handout, and I apologize for that. But the key point here is that cancellous autograft is the best for osteoconduction and osteoinduction. And demineralized bone matrix has fair osteoconduction and good osteoconduction. So those are probably your best graft choice answers for osteoinduction. HO, everyone knows what this is. It's ectopic bone in response to injury or surgery. It's termed myositis ossificans when it's in the muscle. HO is common in closed head injuries and in total hip arthroplasty and Paget scenario. 50% of people can have problems with ectopic bone formation around the joint. There's debate on what the optimal time for resection is, and it's a little bit controversial, so they won't really ask you that, but could be after it's been burned out, and some people advocate early use, early resection. Irradiation is used in adjunct in preventing recurrence of HO, particularly in treatment of elbow contractures and total hip arthroplasties. How does it work? It prevents proliferation and differentiation of mesenchymal cells. That's come up as well. So irradiation stops the whole process from the very beginning. Diphosphonates inhibit mineralization, but you still get osteoformation. So when you stop the treatment with these medications, you end up getting calcification on the osteoid. So it's not a long-term solution. All right. Everyone okay? Conditions of bone mineralization, bone mineral density, and bone viability. This is by far the most difficult portion of this chapter. I'll try to slow down a little bit in this portion, but they like these questions as well. So what's involved with normal bone metabolism? Several things, but calcium and phosphate, PTH, and vitamin D and calcitonin are the main things they ask you about. Calcium. Bone is the reserve for 99% of calcium. It's important in several functions, including muscle and nerve function, and in the clotting cascade. Only 1% of calcium is in the plasma. 50% of it is free, 50% is bound to albumin. But this plasma calcium level is the one that causes quite a bit of problems in calcium disorders, and we'll talk about it in just a few minutes. This is a test question. Calcium is absorbed in the intestines where? It's absorbed actively in the duodenum, and vitamin D, the active form of vitamin D, is what stimulates this, and it's absorbed passively in the jejunum. It's also resorbed in the proximal tubules of the kidney. So whenever someone has a kidney disorder, such as renal osteodystrophy or any kidney problem, the calcium and phosphorus metabolism is severely affected. Another favorite question, what are the dietary requirements? Children have the least, pregnant or lactating women have the most. So 2,000 mg per day for a lady who's breastfeeding. Primary regulators of calcium, PTH and vitamin D. So put this into, you got to know this. What does PTH do? It increases serum calcium and decreases serum phosphate. What does vitamin D do? It increases calcium and phosphate. So both increase calcium, but they act against each other in terms of phosphate. And that's important to put this in your memory because all the hypocalcemic, hypophosphatemic, all those disorders make a lot more sense if you just know this. Phosphate, 85% of body stores in bone. Plasma phosphate is unbound, and this is also resorbed in the proximal tubules of the kidney, just like calcium. So again, kidney disorders can wreak havoc on calcium and phosphate metabolism. The dietary requirements is listed there, and that's rarely a question. This chart shows the complex interaction of calcium and phosphorus, and we'll talk a little bit more about this, but PTH, again, is released by the parathyroids, and we'll talk specifically about this, and it acts at the kidneys, intestines, and bone. One of the key things to know is that PTH increases the active form of vitamin D, 125 vitamin D. Now, we talked about knowing what PTH and vitamin D do, but it's also important to know that high levels of PTH increase 125 vitamin D. And you'll see why I'm fixating on that in just a few minutes. Vitamin D acts at the intestines and the kidneys to stimulate calcium and phosphorus retention. So, the parathyroid hormone, synthesized and secreted from chief cells of 4 parathyroid glands, it regulates plasma calcium and phosphorus, as we've discussed. It directly activates osteoblasts, which stimulate osteoclasts through secondary messenger. So the osteoclast gets stimulated by the secondary messenger and cause bone resorption or calcium resorption from bone. So the parathyroid hormone does not act directly on the osteoclasts. It again modulates renal phosphate filtration, and decreased calcium levels stimulate PTH release, which acts again on intestines, kidneys, and bones. So again, there's a feedback mechanism. When calcium levels go up, PTH is going to go up. Sorry, when calcium levels go down, serum calcium levels go down, PTH is going to go up. PTH-related proteins have been implicated in several things, such as metaphyseal dysplasia. I don't think you need to worry about that. But vitamin D, the other important agent for calcium, is a naturally occurring steroid from sunlight or from dietary intake. We don't see problems with vitamin D deficiency as much anymore since our milk is supplemented with vitamin D. This is key to know. Vitamin D is hydroxylated in the liver to 25 vitamin D, and it's hydroxylated again in the kidney to either 125 or 2425. 125 is the active form, 2425 is the inactive form. And the enzyme that does that is an alpha hydroxylase. And there's a disorder that we'll get to that there's a deficiency in this enzyme, so you can't get at the active form of 125 vitamin D. And here's actually it is. So this chart, if everyone can see, 125 vitamin D is the active metabolite, and it's stimulated by a decrease in calcium and a decrease in phosphorus and an increase in PTH. Remember, increase in PTH increases 125 vitamin D. Vitamin D causes increase in calcium and phosphorus. So any decrease in calcium and phosphorus is going to increase the active form of vitamin D. And that's the alpha hydroxylase is the enzyme. Now, if you have high levels of calcium and a high level of phosphorus, that's a negative feedback loop. So you'll get stimulation and formation of the inactive metabolite of vitamin D. And when PTH decreases, PTH is going to decrease when serum calcium levels return more to normal. And if PTH decreases, that causes more formation of the inactive form of vitamin D. Okay? So, active form works at the intestines, kidneys, and bone. Again, it increases serum calcium and increases serum phosphate. Another favorite question is dilantin impairs metabolism of vitamin D, and it results in situations such as osteomalacia in adults. Here's the vitamin D metabolism. It's from the skin or from dietary intake. The first step is it gets converted to a metabolite 25 in the liver and then gets converted to 125 or 2425 in the kidney. And if there's a kidney disorder, you don't get normal formation of vitamin D. Calcitonin, it's made by clear cells in the parafollicles of the thyroid gland. Clear cells was on the OITE last year, so know it. Main effect is the inhibition of osteoclastic bone resorption. It causes a decrease in serum calcium levels. All right, so it's the opposite of PTH. It's stimulated by increased serum calcium levels, and it's a target for osteoporosis treatment, although still in the early stages. What do you need to know about estrogen? Prevents bone loss by inhibiting bone resorption. But a key thing is bone formation and resorption are coupled, so it inhibits bone loss, but it also inhibits bone formation, or decreases bone formation. So, question, supplementation is helpful in postmenopausal women, but it has to be initiated within 5 years of menopause. If you initiate it afterwards, it doesn't have as beneficial of an effect. This is debate. I know there's recent research out about the combination therapy, but I don't think you'll be asked specifically about whether to combine it with progesterone therapy to prevent increased risk of breast and uterine cancer, but that's the old recommendations. Hormones, briefly, you don't have to know much. Steroids increases bone loss, and it does it by decreasing GI absorption, by decreasing binding proteins. Thyroid hormone causes bone resorption and osteoporosis. Growth hormone actually has an opposite effect. It causes a positive calcium balance and increases resorption of increases GI resorption. Again, you don't need to know much more than what's listed for the test. Peak bone mass, 16 to 25 years of age. It's decreased by 0.3 to 0.5% per year, and after menopause in untreated women, it's 2 to 3% a year. So it's pretty significant bone loss. You've all reached your maximum peak bone mass. Osteoporosis occurs at the onset of menopause, of course. Markers for bone resorption, urinary hydroxyproline and pyridine crosslinks. And markers for bone formation is serum alkaline phosphatase. So estrogen therapy decreases bone resorption, but it also decreases bone formation. So urinary pyridine and alkaline phosphatase are both decreased. And that's been a test question, too. Can you guys read that? I'm bald, so I thought this was funny, but you probably wouldn't. You guys are just so quiet. And I can see there's a lot of bald orthopedic residents here, so makes me happy. All right. Take a deep breath for a second, and this is This is going to be a little difficult. But remember the points I made about what vitamin D does, what PTH does, and how PTH increases the active form of 125 vitamin D, okay? And that you'll get a good understanding of the conditions of bone mineralization. Now, hypercalcemia, here are the presenting signs and symptoms. Polyuria, kidney stones, osteitis, fibrosis cystica, CNS effects being confusion and stupor, and GI effects of constipation. Remember the bones, stones, abdominal groans, and psychiatric overtones, mnemonic, I guess. Hypercalcemia differential diagnosis is enormous. But the main one they're going to test you on is hyperparathyroidism. Okay? Don't have to worry too much about the others, except for malignancy. And we'll talk briefly about that. So primary hyperparathyroidism, it's an overproduction of PTH by a parathyroid adenoma in most cases. It results in an increase in plasma calcium. And remember, PTH decreases plasma phosphate, so it causes enhanced urinary excretion. So the opposite things occur with calcium and phosphate. And it does this by increasing osteoclastic resorption through the secondary messenger that was released by osteoblasts. Diagnosis is made by signs and symptoms of hypercalcemia. You have increased serum calcium, increased PTH, and urinary phosphate because more phosphate is being excreted. So that results in decreased serum phosphate, and you have some bony changes that would like to be discussed by Dr. Parsons. This table should be helpful. Okay, so look at the bold ones there. How do you diagnose it? What labs, abnormal labs, do you see? So in primary hyperthyroidism, you have high levels of PTH, right? So that's up. So what's going to happen to calcium? It's going to go up. What's going to happen to the active form of vitamin D? Since PTH stimulates production of 125 vitamin D, that's going to go up. Okay? And what's going to decrease is serum phosphate. All right? So this is, if you know a little bit about what these agents do, you can really figure out what abnormal labs you're going to have in most cases. There's some histologic changes where you have a lot of activity on both sides of the bone surface. Osteoblasts and osteoclasts are both active. Remember, when you're resorbing bone, you're also forming bone. It's just that resorption is occurring at a faster rate in this particular case. Treatment is surgical parathyroidectomy. Hypercalcemia of malignancy is life-threatening. Results from release of systemic growth factors and cytokines that stimulate osteoclast activity. So you get a PTH-related protein secretion from a lung carcinoma, most commonly an oat cell carcinoma of the lung. And that PTH-related protein causes activation of your osteoclast, again, through the secondary messenger from the osteoblast, and causes increased levels of calcium, which can be life-threatening. Treatment, hydration, loop diuretics, dialysis, mobilization prevents further bone resorption, and you can give them IV bisphosphonates or calcitonin, or try to give them some drug therapy, but very high levels of calcium can be a life-threatening situation. Okay, that's hypercalcemia, hyperparathyroidism. Now let's look at hypocalcemia. Usually low PTH and vitamin D. What are the signs and symptoms? You get neuromuscular irritability with tetany, seizures, and Schwaztek sign. Does anyone know what that is? You remember? It's tapping the TMJ and you get tetany of your your jaw muscles. You also get cataracts, fungal infections of the nail, and EKG changes with a prolonged QT interval. What's that called? Torsades de pointe. It can give you a fatal arrhythmia. So hypocalcemia is very important to recognize and treat. Differential diagnosis, and we'll touch on these. You get hypoparathyroidism, pseudo-hypoparathyroidism, renal osteodystrophy, and rickets. This is a great topic, isn't it? Hypoparathyroidism. Decreased PTH. So what happens? Low calcium. If you don't have enough PTH, you're going to have low calcium, and you're going to have increased plasma phosphate because PTH works to reduce your phosphate level. Common findings, again, fungal infections, vitiligo is one of the findings. Iatrogenic hypoparathyroidism results from thyroidectomy. Remember, the parathyroids are behind the thyroid, so that's actually been tested before. Hypoparathyroidism labs. Again, we can figure this out if we know what everything does. So you have low PTH, so what's going to happen to 125 vitamin D? It's going to be low as well, correct? Because 125 vitamin D production is stimulated by PTH. So if you have low PTH, you're going to have low 125 vitamin D. You're going to have low serum calcium. PTH is the main regulator of serum phosphorus, and it decreases phosphate, but in hypoparathyroidism, it's increased. Pseudo-hypoparathyroidism, you've got to know very little bit about this stuff. It's a rare genetic disorder caused by lack of PTH effect on target cells. So you have a resistance to PTH, similar to how type 2 diabetics have resistance to insulin. You have appropriate amount of PTH, but it's not working at the target cell. If you ever see a kid in the hand clinic that has short first, fourth, and fifth metacarpals and has some other abnormality, you have to think about pseudo-hypoparathyroidism because there's an association between short metacarpals and metatarsals and this disorder called it's Albright hereditary osteodystrophy. So pseudo-hypoparathyroidism labs. You're going to have normal or increased levels of PTH, but it's not working at the receptor, okay? So your serum calcium level is going to be low. If PTH is not working at the receptor, you're going to have low levels of 125 vitamin D because the enzyme that's going to form 125 vitamin D is not responding to the PTH. And you'll have, again, increased levels of serum phos because the PTH is not working. Pseudo-hypoparathyroidism. I don't know why this is in the chapter. I haven't seen this tested, but Dr. Brinker seems to think that this is important. So it's a normal calcemic disorder. It's similar to pseudo-hypoparathyroidism, but I don't know why it's normal calcemic and why there's a normal response to PTH at the receptor level. And if you look at the basic science textbook, it's not even in it. And they don't have an understanding of this disorder, but it's phenotypically similar to pseudo-hypoparathyroidism. This is one of the more difficult ones to understand, renal osteodystrophy. Anyone with kidney disease can have this problem. It's a very broad spectrum of disorders in bone metabolism. It affects calcium and phosphate metabolism. It can cause osteomalacia in adults, and it can also cause deposition of calcium in the soft tissues because of the abnormal calcium phosphorus metabolism causes them to bind in soft tissues, and I'm sure you've all seen patients with renal osteodystrophy who have deposits all over their body. But impaired renal function compromises mineral homeostasis. There's two types: high turnover disease, which is due to a chronically elevated PTH, and a low turnover disease, which results from aluminum deposition in the bone, and it prevents release of PTH. And I know this is frustrating, guys, but just try to follow along and look back at those charts because they'll all make sense once you know those few points I made. So high turnover disease leads to secondary hyperparathyroidism. Okay? Why is that? You have high levels of phosphorus in people who have kidney disease. So what's your body going to do when it sees high levels of phosphorus? It's going to try to reduce it. What agent does that? PTH does that, right? So PTH, there's going to be high levels of PTH. And when you have high levels of PTH, that will result in the problems with this disorder. So phosphorus retention promotes secretion of PTH through several mechanisms. Hyperphosphatemia is the main one. Okay? So again, looking at the labs, you have increased levels of PTH because of the increased levels of serum phosphorus. Okay? Serum calcium is probably normal in these people. There's a little bit of variability because this is a spectrum of disease. Now, 125 vitamin D is usually increased when PTH is increased. But for some reason, when you have high levels of phosphorus, so what does 125 vitamin D do? Right? It increases calcium and phosphorus. If you have already high levels of phosphorus or phosphate, it's going to go down. And that's why your 125 vitamin D is decreased in this particular situation. The key to all the questions that are asked on the renal osteodystrophy is they will tell you that the BUN and creatinine are increased, and that's a giveaway. Okay? That should tell you right away that you have kidney disease and you're dealing with renal osteodystrophy. So how do you treat? Very difficult. Reduce the phosphate load. You give them antacids to bind phosphate. It's been a long time since any of you have taken care of transplant patients or anything like that, but if you can correct the renal disease, that's the goal. and a transplant is one of the goals in people who have very difficult problems and are candidates for that. Now, you also have low turnover disease, which is adynamic. It can be either adynamic or osteomalacia. In this case, there's no hyperparathyroidism. So that's what differentiates it from high turnover renal osteodystrophy. Okay? Bone formation and turnover is reduced, and that's because of aluminum toxicity. You're giving all these antacids to these dialysis patients. This aluminum is not secreted, and it gets deposited in the bone, and that wreaks havoc in the normal mineral metabolism. Treatment is the same. You want to try to get them a new kidney if possible. So what does aluminum do? It impairs differentiation of precursor cells to osteoclasts. It impairs proliferation of osteoblasts. It inhibits the release of PTH. That's why you have low levels of PTH, even though you're going to have high levels of phosphorus or phosphate. Okay? And it disrupts the whole mineralization process. And that's why you get an osteomalacia picture with this particular situation. The adynamic lesion is the most common. You just get slow bone turnover and formation because it disrupts the whole mineralization process. The aluminum does. And or you can get osteomalacia, which is a defect in the mineralization process on top of the slow bone turnover and formation. So what happens with the low turnover disease? You have increased serum phosphorus. You don't have hyperparathyroidism because the aluminum is inhibiting the parathyroid hormone production. And where is the active form of vitamin D created? Kidney, right? So that's why whenever you have kidney disease, you won't ever have the normal 125 vitamin D production. Problems with chronic dialysis. You get beta-2 microglobulin, which is amyloidosis, and stains pink with Congo red. I'm sure you guys remember that question from before, but that's another, they like that for some reason. It can cause carpal tunnel syndrome, arthropathy, and pathologic fractures. Very complex chart of renal osteodystrophy. Take a few seconds to look at it, and I think it'll make a little more sense. In chronic renal disease, you have reduced synthesis of 125 vitamin D. There on, is it showing up on your right side? And the kidney disorder causes hyperphosphatemia, and that results in several things. It can cause either secondary hyperparathyroidism in some situations, and if you do have secondary hyperparathyroidism in the high turnover disease, you'll get increased levels of calcium, and you could, because of the increased levels of calcium and phosphorus, because the kidney's not secreting phosphorus, you'll get ectopic calcification, and that's why you do see some of that ectopic calcification in renal osteodystrophy. But at the same time, on the low turnover side, you don't get high levels of PTH, and you can get the rickets or osteomalacia in the adult because you don't have normal mineralization or normal bone formation and turnover secondary to the aluminum toxicity. I don't know how to make that much more clear. It's a very difficult topic to have clinicians and non-basic scientists understand. And of course, it's really not, you just got to know it for the exam. Just put it in short-term memory. It's going to require a bit of memorization to do that. Rickets is the other common hypocalcemic disorder. It's a failure of mineralization in the zone of provisional calcification or hypertrophy. It leads to changes in the physis and cortical bone. The physis has increased width. The bone has cortical thinning and bowing. Causes nutritional deficiency, which is rare nowadays. You can have several other causes, renal tubular defects, and the main one to know that we're going to talk about is nutritional rickets and some of the hereditary types. But the nutritional rickets can result from vitamin D deficiency, calcium deficiency, and phosphate deficiency. Vitamin D deficiency rickets are rare because they've added vitamin D to milk. It's seen in premature infants and malabsorption syndromes. The treatment is vitamin D. Makes sense, right? Here's some of the what you can find: enlargement of the costochondral junction, bowing of the knees, delayed bone growth because of effects on the hypertrophic zone of the growth plate, dental disease, fractures. You get physeal widening, cupping, and coxavera. Here's a picture of rickets. You can see the widened growth plate, and the pathology there shows a very broad hypertrophic zone, and you don't get the normal calcification you need in the provisional zone of calcification, and that's the pathologic cause of rickets. Here's the labs, right? What's deficient? Vitamin D. So 125 and 25 vitamin D are going to be low. Chances are, if those are low, your calcium and phosphorus are going to be low, because what does vitamin D do? It increases serum calcium and phosphorus. So if it's low, your calcium and phosphorus are going to be low. You're going to have a problem with mineralization of your bone. What's increased? When you have low calcium levels, PTH is going to go up, right? So that's why PTH is increased. Calcium deficiency rickets, it's hypocalcemia because of calcium deficiency, and that leads to an increase in PTH. What does PTH do again? Converts to the active form of 125 vitamin D. So the labs you have is you have decreased serum calcium because your body doesn't have enough calcium. Your serum phosphate is low because you have high levels of high levels of PTH, right? And increased levels of PTH and the 125 vitamin D. The reason your serum phosphate, even though 125 vitamin D is high, your serum calcium is low because you don't have enough in your diet. You don't get enough absorption from the GI tract, okay? And even though it's rickets in children, it's called osteomalacia in the adults. So treatment, give them calcium. Phosphate deficiency rickets is a little bit more difficult to understand. You have decreased serum phosphate, which increases 125 vitamin D, right? You don't get secondary hyperparathyroidism because what's going to stimulate PTH secretion is going to be high levels of phosphate, right? PTH tries to decrease the level of phosphate, but you already have low levels of phosphate, so you won't get the secondary hyperparathyroidism. Labs, normal serum calcium, PTH, and the main lab is decreased serum phosphate. And when you see that, it's phosphate deficiency rickets. Okay? And the decreased serum phosphate, again, is going to stimulate 125 vitamin D. How do you treat it? Oral phosphate. Hereditary vitamin D dependent rickets. This is very rare. It's been tested before, type 1 and 2. It's similar presentation to vitamin D deficiency, but it's worse. It's much more difficult to treat. Type 1 is pseudo-vitamin D deficiency. Remember I told you about that enzyme that converts 25 vitamin D to 125, the active form? Well, there's a defect in this alpha hydroxylate. So you don't get the active form of vitamin D. It's autosomal recessive. It's been localized on a chromosome, and treatment is supplementation with the active form of vitamin D. Here are the labs. Serum calcium is down, serum phosphorus is down because your 125 active form of vitamin D is low. So you're not getting the normal absorption from the GI tract and the kidneys of the serum calcium and phosphorus. So if your serum calcium is low, what's going to happen to your PTH? It's going to go up, right? Now look at the ones I've highlighted in red. 25 vitamin D levels are going to go up because it's not being converted to 125. So there's no negative feedback going on to say, okay, stop making 25 vitamin D. The liver is not being told, okay, stop converting vitamin D to 25 vitamin D because the enzyme's not working in producing 125 vitamin D. So you can diagnose this deficiency if they give you labs based on that fact. This is type 2 hereditary resistance to vitamin D. There's a defect in the receptor for 125 vitamin D. So 125 vitamin D is being produced. Okay? That's the difference between type 1 and type 2. But it has no effect. So there's no response to the active form of vitamin D. It's a similar presentation to vitamin D deficiencies that we've discussed, but it's much more severe and it's very difficult to treat. So the labs, if you go back a couple slides ago, you saw that 125 was decreased and 25 was increased. Well, in this case, 25 and 125 are increased, but since there's no effect at the receptor for 125, you're not getting the negative feedback to decrease the levels of 125 and 25 vitamin D. This all kind of making sense? I mean, I know it's confusing, but I hope these tables are helpful in trying to make things a little more clear. So if 125 and 25 vitamin D are not working at the receptor, your serum calcium and phosphorus levels are going to be low. If your serum calcium level is low, what's going to happen to your PTH? It's going to go up. Okay? So there's a lot of feedback loops here that you have to be familiar with. So familial hypophosphatemic rickets is the most common form of rickets. It's known as vitamin D resistant rickets and phosphate diabetes. It's an X-linked dominant disorder. One question was, familial hypophosphatemic rickets is what type of hereditary disorder? It's X-linked dominant. Okay? It results in impaired renal tubular resorption of phosphate. It's, again, the most common form of rickets. When phosphate is not absorbed properly, it again will wreak havoc on the whole calcium phosphate metabolism, and treatment is phosphate supplementation. Here, hypophosphatemic. Again, hypophosphatemic tells you that you have decreased serum phosphate. You have, in this case, this is a little more confusing to understand. If you have decreased serum phosphate, the active form of vitamin D should be high, right? Because 125 vitamin D wants to preserve phosphate, but since there's a defect in the kidneys and you can't preserve phosphate, 125 vitamin D should be very high, and it's not. It's normal in this disorder. So there's a problem, a genetic problem with this that results in a hypophosphatemic, and even though serum calcium levels may be normal, they're not at the appropriate levels based on the low levels of serum phosphate. So it presents as either rickets or osteomalacia in the adult, yet the triad is limb deformities, delayed growth, and hypophosphatemia. Hypophosphatasia is a different disorder. Autosomal recessive disorder, it's an inborn error that leads to the low levels of alkaline phosphatase, which is required for inorganic phosphate. Similar to rickets and osteomalacia, diagnosis is based on increased urinary phosphoethanolamine. There is no treatment that we know for this, but the giveaway for hypophosphatasia on the test is if you have a lab with decreased alkaline phosphatase. This is the only one that has decreased alkaline phosphatase. You don't have to know anything else about this disease. If you see decreased alkaline phosphatase, it's hypophosphatasia. Okay? Probably feel pretty bad right now, I know. So let me just get through this bone section. It gets a little bit easier here, and go over quick test questions, and then we'll take a break, okay? So, a few more minutes, just a little more to do here. So, conditions of bone mineral density: decreased bone mineral density, increased bone mineral density, or both, okay? Osteopenia is seen in the following conditions: osteoporosis, osteomalacia, scurvy, myeloma, and osteogenesis imperfecta. A lot of these details of this may be covered in the pathology section, but osteoporosis, of course, everyone knows the details about this. Age-related decrease in bone mass. It's more common in postmenopausal women. 1 million fractures per year. It's a quantitative, not qualitative defect in bone. So the bone's normal, but you just don't have enough of it. Risk factors you need to be familiar with: sedentary lifestyle, thin Northern European descent, smokers, drinkers, dilantin can cause osteoporosis or osteomalacia. Cancellous bone is the most affected. Two types of osteoporosis. Type 1, which is postmenopausal, affects trabecular bone mainly and results in what we see every day, vertebral and distal radius fractures. Type 2 is age-related. Patients are older than 75 years old. Affects both trabecular and cortical bone. Poor calcium absorption. This is an age-related phenomenon. It's called senile osteoporosis. Hip and pelvic fractures are more common. We know the clinical features: kyphosis, vertebral fractures, hip fractures, and distal radius fractures. Lab studies are normal. Radiographs are only helpful if you have more than 30% of bone loss. DEXA is the most accurate diagnostic tool. Histology, you get thinning of trabeculi, decreased size of osteons, and enlargement of haversian and marrow spaces. This is a slide showing a 24-year-old on your left and a 89-year-old on your right, and you can see the thinning of the trabeculi. Treatment: physical activity, calcium supplementation, estrogen progesterone therapy for postmenopausal type, bisphosphonates, which inhibit osteoclastic membrane ruffling without destroying the cell. Okay, so it inhibits that ruffled border. Prophylaxis for osteoporosis: diet with adequate calcium, weight-bearing, exercise program, and estrogen therapy at menopause. This is a chart to commit to memory. Decreasing bone loss is provided by these bisphosphonate therapy. Halting loss is calcium, vitamin D, calcitonin, estrogen, and exercise. Fluoride is the only agent that actually increases bone mass, and although it's not commonly used for treatment at this point because of some of the side effects, I think they're investigating this. The endocrinologist can help you out more with that. Osteomalacia is a defect in mineralization. It's the spectrum of rickets seen in the adult. You have large quantities of unmineralized osteoids. So while osteoporosis is a quantitative defect in bone, osteomalacia is a qualitative defect in bone. You have a lot of abnormal or non-mineralized bone present. It's seen in a variety of conditions: vitamin D deficient diet, GI disorders, renal osteodystrophy, and antacids and dilantin. The antacids, of course, are used in dialysis patients to counteract their high levels of phosphate, and the antacids all have aluminum, and that we talked about how aluminum affects bone formation and resorption. It's associated with alcoholism and looser zones. I'm sure Dr. Parsons will cover for the pathologic portion of osteomalacia. X-rays, biconcave vertebral bodies, trefoid pelvis, biopsies required for diagnosis, and you see widened osteoid seams. Treatment is the same essentially for vitamin D deficient rickets. Give them large doses of vitamin D to allow for mineralization. Scurvy, we don't see it that commonly. It's vitamin C deficiency. What does it do? It causes a decrease in chondroitin sulfate synthesis. It causes defective collagen growth and repair. It impairs intracellular hydroxylation of collagen peptides, particularly proline. Clinical features are fatigue, bleeding gums, and joint effusions. Labs are normal. Histology, primary trabeculi is replaced by granulation tissue. Remember how things seem to happen in the hypertrophic zone of the physis, and this is one of them. They like that question, and if you don't know the answer, guess hypertrophic zone, one of the portions of the hypertrophic zone, and chances are you have a high chance of getting that question right, because that seems to be their favorite zone for some reason. Now, it has the greatest effect also from the hypertrophic zone into bone formation and metaphysis. Treatment is simple: vitamin C. Give them some oranges. OI, abnormal collagen synthesis. Again, these are diminished bone density problems. You have a failure of normal collagen cross-linking. It's a mutation in a gene responsible for production of collagen type 1. A few increased osteodensity conditions you need to know: osteopetrosis or marble bone disease, osteopoikilosis, which I'll be surprised if they ask you on, and Paget's, which is actually a both increase and decrease osteodensity condition. Osteopetrosis, which I know Dr. Parsons has touched on, increased sclerosis and obliteration of the medullary canal. It's due to a decrease in osteoclastic function. Histologically, osteoclasts lack normal ruffled border. Okay? That's a test question right there. Marrow space filled with necrotic calcified cartilage. There's two types: autosomal recessive infantile malignant form, which is the most severe type. It's associated with hepatosplenomegaly, aplastic anemia, and death. Treatment is bone marrow transplant. The less severe form is autosomal dominant. Remember, in most cases, autosomal recessive disorders are the more severe. But in this case, this follows that pattern. Autosomal dominant, the Albers-Schönberg disease, is generalized osteosclerosis and results in multiple pathologic fractures secondary to the brittle bone. Even though the bone is osteosclerotic and very dense, as you can see on this picture, it's brittle, so you tend to get fractures. Osteopoikilosis is spotted bone disease. You get deep cortical bone within the medullary canal. These are bone islands. They're asymptomatic. There's no incidence of malignant degeneration. Paget's, I think Dr. Parsons will touch on this as well. There's two phases: active and inactive. Diagnosis is based on elevated serum alkaline phosphatase, which is a marker of bone formation, and elevated urinary hydroxyproline, which is a marker of bone resorption. So you get both in Paget's. In the active phase, you can have the lytic phase where you have excessive resorption. You can have a mixed phase where both are present, in the sclerotic phase where bone formation actually predominates, and you're going to have high levels of serum alk phos. Here's an X-ray, and if you look at the histology, you actually see that there's woven or less organized bone, and there's more lamellar or more organized bone, and that's pathognomonic for Paget's. You guys remember this guy? I think this happened in Europe. I'm sure it wouldn't happen in the U.S. Last section before the test questions. Okay, osteonecrosis. Again, this is probably going to be touched on in the pathology section. It's death of bony tissue as a result of a vascular insult. It can be idiopathic. Leg-Calvert's disease is a osteochondrosis. There's a question of whether it's related to coagulation abnormalities. Femoral head is the most common location. Everyone's seen an MRI of AVN of the femoral head. Risk factors, steroid use, heavy alcohol use, sickle cell disease, Caisson's disease, which is, I guess, the bends and deep-sea divers, excessive radiation therapy, Gaucher's disease, and hemochromatosis. Etiologies are variable, enlargement of marrow fat cells leading to ischemia of adjacent tissue, vascular insult, and then idiopathic is usually the most common cause because we can't figure out why, and that's Chandler's disease, no identifiable cause. What you need to know pathology-wise, you get a combination of necrotic bone, fibrous tissue, and subchondral collapse. Histology is necrotic marrow. You get woven bone laid down on dead trabecular bone. Resorption of dead trabecular bone occurs and remodeling occurs, and that's, again, creeping substitution. So in cancellous bone grafts and in osteonecrosis, the answer is creeping substitution. During creeping substitution is when you get collapse, and that's when you get the crescent sign. How often is it bilateral? 50% of cases of idiopathic osteonecrosis and 80% of steroid-induced osteonecrosis. MRI is helpful. What are osteochondroses? They occur in children. They have a similar pathology as osteonecrosis in adults, but they occur at the traction apophysis in children. It's either trauma or a vascular insult. You got to memorize these names, okay? I know it's a pain. You know most of them. Osgood-Slaughters, Sinding, Larson, Johansson, Sievers, Kohlers, Freibergs, Kienbachs, Blounts. You have to know them. They're going to pop up. All right, probably all feel like that right now. I do too, don't worry. Let's go over a few test questions and we'll take a break, okay? All right, at what time, and just please yell out the answer if you know it. At what time after fracture is there a maximal vascular response at the fracture site? 2 weeks, right? The common pathologic process that occurs in patients with rickets, regardless of the cause, is failure to... Someone? Anyone? Bueller? What's the answer? Yeah. Okay. What is the primary effect of vitamin D? Please get this. One. Good. What of the following is considered a key characteristic of osteoblasts? What was that? Right. Remember. And that's how it affects osteoclasts through a secondary messenger. These are right out of your OITE and all the self-assessment exams. So this is the detail they expect you to know for basic science. Process of host repair following osteonecrosis is referred to as creeping substitution. Good. During the repair process of an unstable fracture, the expression of major collagen types during fracture callus formation can best be characterized by. So what do you have? Endocrinal ossification. What order do you have? Too early, followed by type 1, right? Which organ secretes calcitonin? Thyroid, right? Right. Which of the following groups is most at risk for osteoporosis? This is all you should know. What metabolic bone disease is associated with abnormal osteoclastic function? Osteopetrosis. 65-year-old man who has had dull ache in the tibia for several years now has pain so acute that he must use crutches. Level of serum calcium and phosphorus are normal, but alkaline phosphatase level is elevated. The diagnosis most likely is, you can go by the age and the location, but it's going to be Paget's. Because the following is not a manifestation of hyperparathyroidism. Hyperparathyroidism, right? So you get hypercalcemia. A, right? Because hypocalcemia is associated with excitability of the central nervous system. This, you barely have to read this question to get the answer. An 8-year-old is, I guess this isn't a very politically correct question anymore, but has bowed legs. Calcium is low. BUN and phosphate and alkaline phosphatase are elevated. The most likely diagnosis is renal osteodystrophy, right? BUN and phosphate, BUN is elevated. They're giving you that this guy has renal disease. Parathyroid hormone exerts an effect on the intestines by, please get this too, stimulating production of 125 vitamin D. The major physiologic effect of calcitonin is anyone? Inhibition of bone resorption, right? A 3-year-old boy with frequent fractures and progressive deformity of long bones, all right, with a normal serum calcium and phosphorus and a low serum alkaline phosphatase level, most likely has. I mean, most of you might think he has OI, right? That's what I thought until I read a little bit more into the question. What was the one thing? Low serum alk phosphatase, right? So what is the answer going to be? Hypophosphatasia. It's a piece of cake, you know. There's few things that they look for. They're not going to get more detail than that. If you see low alk phos, you've got to know what it is. Vitamin D is converted to 25 vitamin D in which organ? Liver. And it's converted to the active form, 125, in which organ? Kidney. Bisphosphonates are a family of compounds used in treatment of a variety of metabolic bone disorders. Which of the following osteoclastic functions is most directly affected by these compounds? Right? What component of frozen allograft bone has the least amount of immunogenicity? Hydroxyapatite. Fully differentiated osteoclast has receptors for which of the following proteins? Which one? Calcitonin. All right, guys. Let's just 5-10 minutes be back because I still got 2 more sections to cover. The limit on that, okay? They're not going to go crazy because the truth is that even the people who are writing the questions may not have a complete understanding of it either. So just be rest assured, you all, if you know this, what's in the syllabus, you should do well on the basic science section, okay? And I'm proof of that. I sat through these same lectures, so I know I feel pretty confident that you guys are going to do great. All right, let's get started. So we're going to talk about neuromuscular and connective tissue. This is section 3 in the chapter, okay? Section 3 in that first chapter, the basic science chapter. Skeletal muscle, nervous system, and connective tissue. Start with skeletal muscle. It's composed of non-contractile elements and contractile elements. We'll discuss the action of skeletal muscle, the types of muscle contraction, type of muscle fibers, the energetics and athletics and training. Okay, the non-contractile components of muscle. This is just the anatomy, essentially. The muscle body. You have muscle bundles, which are surrounded by epimysium. You have muscle fascicles surrounded by paramysium. And you have individual muscle fibers surrounded by endomysium. Just know the definitions. This will be on your test. It always is. The weakest link, site of injury, is the myotendinous junction with an eccentric muscle contraction. What's the sarcoplasmic reticulum? I know I have a picture of it in my syllabus, but all it is the component of the skeletal muscle that stores calcium necessary for muscle contraction. All right, here is just a diagram, the epimysium, paramysium, endomysium. The fiber is made up of myofibrils, which we'll talk about in just a second, okay? The contractile elements of skeletal muscle are derived from myoblasts. The muscle, again, is composed of fascicles, fibers, and the fibers are composed of myofibers. The myofibril is a collection of sarcomeres, which is the contractile unit of the skeletal muscle. This is all from basic biology, right? Skeletal muscle, there's a picture. You see the fascicle, the fiber, the myofiber, and the myofiber is made up of the sarcomere. The sarcomere is composed of thick and thin filaments, which are arranged to allow them to slide past each other for contraction of the muscle. What are the thick filaments? Myosin. Thin filaments are actin. This is EM of a sarcomere. You got to know these zones. I know you knew them when you were in high school and college. Just put them in the short-term memory bank for the test. Okay? The H band is the thick filaments. I band is the thin filaments or actin. The Z line is the attachment of the thin filaments. A sarcomere is a Z line to a Z line. The A band contains both actin and myosin, and the M line is the interconnecting site in the middle for the thick filaments. I think you can get a little better idea of this on the next slide here in your syllabus about the thicker ones are the myosin and the thin ones are the actin, okay? I know it's a pain in the ass, but you just have to know it. Action. How does it work? To get a muscle contraction, it originates in the cell body of a nerve. It's propagated down the axon. It reaches the motor end plate, and acetylcholine is released by presynaptic vesicles. Okay, and then if you have disorders or problems with release of acetylcholine, you get things like myasthenia gravis. Now, acetylcholine diffuses across the synaptic cleft and binds to the receptor on the effector organ or muscle membrane. When you get the receptor is stimulated, you get depolarization of the sarcoplasmic reticulum, and the sarcoplasmic reticulum releases calcium. Calcium is the main thing that initiates the process for the thick and thin filaments to slide past each other and to cause a muscle contraction. Here's a diagram of the axon, the synaptic cleft, and the release of acetylcholine. So what are the two regulatory proteins for muscle contraction? Remember this, guys, troponin and tropomyosin. I probably haven't heard that for a while, but they're the regulatory proteins. Tropomyosin prevents cross bridges from binding actin. So it's in there, in between, lodged in between the actin and myosin, and it's not moving until something is done. Troponin is attached to the tropomyosin. That's the receptor for the calcium. It's calcium sensitive. So when calcium binds troponin, it causes tropomyosin to move away from the area between the thick and thin filaments, and then the cross-bridging can occur, and you get sliding of the thick and thin filaments past each other, and that results in muscle contraction. So you can see on the bottom portion of that diagram that you get sliding of the actin and myosin, and that's a contraction of a sarcomere. Okay, types of muscle contraction. This is a favorite question, too, at least on the OITE. You have isotonic. By the title, muscle tension or tone is constant through a range of motion. Muscle length changes. It's a measure of dynamic strength. It's a bicep curl, right? And when you do a curl, you do a concentric reaction, contraction of the muscle. When you do a negative, you get eccentric contraction of the muscle, and that's when you get potential for muscle injury. It's during an eccentric contraction. Isometric, as it's named, the muscle length is constant. Tension changes. It's a measure of static strength. It's like doing push-ups against the wall. Isokinetic. So muscle velocity is constant. Tension is generated through a range of motion, and it's a measure of dynamic strength. It's best for maximizing your strength, but you can't do it without special machines such as the Cybex machine. Muscle fibers. Slow twitch, which is type 1, and fast twitch, which is type 2, A and 2B. Slow twitch fibers are the type 1 fibers. They're oxidative, so they're more colored red because they have more mitochondria. It's an aerobic metabolism. Slow red ox is the mnemonic in the chapter. They're seen in people who have high levels of endurance, so they're seen in long-distance runners have more slow twitch fibers. Fast twitch fibers are type A, 2A and B. They're white-colored. They're glycolytic, so they're anaerobic. They contract very quickly, and they're very large motor units, large muscle mass. So They're anaerobic, they're less efficient, they have a lot of contraction capability, but they fatigue rapidly. So they're suited for high-intensity, short-duration activities such as sprinting. So sprinters have more fast-twitch fibers than slow-twitch. The energetics. You guys are going to love this. 3 energy systems generate muscle activity. You have which system depends on the duration or activity of muscle activity required. So you've got the adenosine triphosphate creatinine phosphate system, or the phosphagen system, the lactic anaerobic system, which is the glycolytic system, and the aerobic system, which is oxidative, and the Krebs cycle. Phosphagen system meets the metabolic requirements for intense muscle activity that lasts for 20 seconds. So a 100-meter dash, for me, probably a 20-meter dash, but it takes me quite a while, pretty slow. So it's carbohydrates from within the muscle fiber itself are used for energy. Does not use oxygen and does not produce lactate. Energy is derived from high-energy phosphate bonds. This was a question on self-assessment exam. Phosphagen system, where is the energy derived from? High-energy phosphate bonds from the ATP that is in the muscle fibers itself. It breaks down to ADP and phosphate, or AMP and phosphate, and you get energy. The anaerobic system is glycolytic. It's the next stage. It meets the metabolic requirement for episodes of intense muscle activities that last for 20 to 120 seconds. So up to 2 minutes, you're going to be in an anaerobic phase. You get hydrolysis of glucose muscle molecules to produce lactic acid and energy. Enough energy is present to convert 2 molecules of ADP to ATP from 1 molecule of glucose. So it's a very inefficient system. Right, you only get 2 molecules of ATP for energy use. The aerobic system is oxidative. It's when oxygen is available. It's responsible for the replenishment of ATP. It has the Krebs cycle. Glucose and fatty acids are converted to ATP. It meets the metabolic requirements for much longer duration, lower intensity muscle activities. So a long run, you're going to be using mainly aerobic or oxidative phosphorylation as your energy source than the other 2. And 34 ATP molecules per glucose. And I know you remember seeing that as a test question before. So here is oxidative phosphorylation, and the Krebs cycles. You don't have to know the details of this, okay? But you need to be familiar with this. So the ATP creatinine phosphate system, or phosphagen system, is the first source of energy. Then you convert to the glycolytic or anaerobic system. And then for long duration activities, you have the oxidative phosphorylation system. Athletes in training, you have a distribution of fast twitch and slow twitch fibers that are genetically determined. Again, slow twitch fibers are seen in endurance athletes. For some reason, the Kenyans seem to have a monopoly on all the slow twitch fibers, and they were 1 through 9 in the last marathon, New York or Boston Marathon. But they have high levels of slow twitch fibers, and that is seen in endurance athletes. Selective training can improve function and efficiency of the fibers, but it doesn't necessarily change your genetic makeup of the fibers. Sprinters have high levels of fast twitch fibers. Who knows what Michael Jordan has? Something, obviously, a tremendous athlete. So training-wise, endurance. What does endurance do? To improve endurance, you want to decrease your tension and increase your repetitions. And that increases the number of mitochondria, capillary density, and oxidative capacity. Okay, so that increases your capability for using an aerobic mechanism for your source of energy. To increase your strength, or train for strength, you want to increase your tension and decrease your repetition. So you want to max out when you're lifting, and that causes hypertrophy of fast twitch fibers. Contractile strength is proportional to the cross-sectional area of your fibers, and isokinetic exercises, and those are the ones that you need to use the Cybex machine for, produce more strength. This is a question that I've seen once, and I don't know why there's an emphasis on it, but plyometric exercises are related to power. Just remember, plyometric, P equals power. So what type of exercise are these? These are muscle stretching cycle followed by a shortening cycle. The stretching leads to storage of elastic energy, and then you go ahead and perform the contraction, but this can also put you at risk for energy because you are stretching your muscles and then doing a very quick contracture, but it could also be an eccentric contracture. They like questions on anabolic steroids. Look at that list, that the effects of steroids. Yeah, it helps your muscle strength, it helps your aggressiveness, but it does cause some negative effects: testicular atrophy, decreased testosterone and gonadotrophic hormones, gynecomastia in males, hypertension, acne and alopecia, liver tumors, and hypercholesterolemia. They like asking questions on and steroids. The female athlete is another favorite topic. The female athlete, particularly long-distance runners and marathon runners, have problems with anorexia, osteoporosis, and amenorrhea. Amenorrhea is it results from a decrease in the percentage of body fat and hormonal changes in the hypothalamic pituitary axis. Muscle injury. Muscle strains are injuries to the myotendinous junction. Muscle soreness results from eccentric muscle contraction and changes in the I band of the sarcomere. Don't know if they'll be specific enough to ask that. I doubt it. Muscle tears are a result of injury, again, at the myotendinous junction. It results from rapid eccentric contraction. Muscle tears tend to heal with dense fibrous tissue. If you do have a mid-substance muscle belly tear, and it's going to heal with dense fibrous tissue, you're going to only have half the muscle strength after recovery. Again, myotendinous junction. Okay. See, that was a lot easier than that bone chapter, wasn't it? Nervous system. Is divided into CNS and the peripheral nervous system. Obviously, they're going to ask more questions on the peripheral nervous system in orthopedics. Just some factoids that have come up. Stroke patients improve up to 6 months after a vascular event. Traumatic brain injury can improve up to 18 months. Folic acid supplementation is important for prenatal vitamins to reduce the incidence of children born with myelomeningocele. I'm sure that will be touched on in pediatric orthopedics. There's some debate. This is the answer right now still, I think. So patients seen within 3 hours after a spinal cord injury, you know what to give them. I know there's a lot of research going on, and this may vary at your institution, but I don't think it's going to change just yet. You all know those. Concussion, you need to know the different grades of a concussion, and Dr. Miller may talk a little bit more on handling the athlete who's been injured, but grade 1 concussion is mild. There's no loss of consciousness. There's no retrograde amnesia. You return to play when you're asymptomatic. Long-term suspension of play for a third time grade 1 concussion. Those are the current recommendations. Grade 2 is moderate. You have loss of consciousness of less than 5 minutes. You get retrograde amnesia. Confusion and disorientation resolves rapidly. The first episode you have a return to play after being asymptomatic for at least a week. If you have repeat episodes, again, long-term suspension of play. Grade 3 is the severe injury, prolonged unconsciousness, permanent retrograde amnesia. Again, in grade 2, you have retrograde amnesia, but then it improves. This is permanent. Confusion and disorientation persist, and you have a long-term suspension of play if you do have a grade 3 concussion. And as people who follow the NFL, there's a lot of quarterbacks who have been urged to not play anymore because of their frequent or number of concussions or severity of concussions. Just the peripheral nervous system basics. Nerve is a bundle of axons enclosed in a connective tissue sheath. There's a nerve fiber is an axon plus the surrounding Schwann cell sheath. Myelinated fibers equal faster conduction velocity. That's a favorite question. Unmyelinated fibers are slower conduction velocity. Here's an EM of the top slide, shows a large myelinated fiber. It's much larger than the smaller ones that you see there on the bottom. In the middle there are unmyelinated. Neuron is composed of the following elements: a cell body, which is the metabolic center, an axon, which conducts action potentials. Dendrites receive input from surrounding nerve cells, and presynaptic terminal transmits information from one neuron to another, or a neuron to the effector organ. Here's a picture of a neuron. Just know the basic anatomy. This is a review from biology. The glial cells involved in the nerve, the Schwann cells, are the ones that we get tested most often on. They myelinate the peripheral the nerve axons. A loss of myelin sheath disrupts conduction velocity. That's what's seen in neuropractic lesions. You get selective demyelination, and that slows your conduction velocity. Myelin is, this was a test question too, 70% lipid, 30% protein. It's mainly fat. Oligodendrocytes are the glial cells in the CNS, and they form myelin. Astrocytes are the most common glial cell, but they're also in the CNS. Here are the pictures of your Schwann cells as they form around the axon or nerve fiber. What is the impulse or potential of the nerve? All nerves have a baseline resting potential. There's an unequal distribution of ions on either side of the neuronal cell membrane. Particularly sodium is the big one, right? So it's minus 50 to minus 80 millivolts. Action potential occurs when an action potential allows for transmission of a signal to another neuron or an effector organ. You get depolarization, and the action potential results from an increase in cell membrane permeability to sodium. And there's 3 types of sodium channels: voltage-gated, mechanical-gated, chemical transmitter-gated. Don't need to know that much specifics, but you just have to know that the flux of sodium is what causes your action potential. So what happens? You get a stimulus, increased cell permeability to sodium, depolarization, action potential, and transmitter release at the presynaptic junction. Action potential. You're in a negative state, you depolarize, you overshoot into a positive state, and then you repolarize after the stimulus is passed. You see there's a threshold level, so you have to have enough flow of the sodium ions across the gated channels before you reach that threshold and you actually get the full depolarization and transmission of the stimulus. Just basics again. What's the sensory system composed of? Stimulus from an environment transmitted via sensory receptors to the CNS. You have several types of sensory receptors: photoreceptors, mechanoreceptors, thermoreceptors, chemoreceptors, and pain receptors. Somatosensory input is transmitted to the spinal cord via the dorsal root ganglion. Right? The motor system is composed of spinal cord, brainstem, cortex, basal ganglia, and cerebellum. The spinal cord has white matter peripherally, which is ascending and descending tracts of myelinated and unmyelinated axons. Gray matter centrally, which is the neuronal cell bodies, glial cells, dendrites, and axons. A picture of with white matter, gray matter. Remember, dorsal root ganglion is the sensory. Ventral root is more motor. And then once you get into the spinal nerve, they're mixed nerves. 3 types of neurons in gray matter: motor neuron, axons, which exit the CNS via the ventral root. Interneurons remain in the spinal cord, and tract cells send axons that ascend to supraspinal centers. You're not going to be asked on tract cells. You'll be asked on motor neurons and interneurons. Interneurons are important because they're involved in the reflex response. Spinal cord reflex is a stereotyped response to specific sensory stimulus. The reflex pathway is the following: sensory organ, interneuron to motor neuron. A monosynaptic reflex, which is rare in humans, there's only one synapse involved. A polysynaptic reflex involves multiple interneurons, and that's what most human reflexes are. Motor unit is composed of a motor neuron and the muscle fibers it innervates. There's 4 types of motor units. They're not that important to know the differentiation, but they're easy to figure out. Type S is slow, fatigue resistant. Type FR is fast, fatigue resistant. FI is fast, fatigue intermediate, and FF is fast, fatigue. Of course, we know about upper and lower motor neurons. Upper motor neurons are located in the descending pathways of the cortex, brainstem, and spinal cord. They're the ones that result in spasticity. If there's injuries at that level, lower motor neurons are located in the ventral gray matter of the spinal cord. Everyone is familiar with motor neuron lesions, upper and lower. Of course, with upper, you have increased DTRs and Babinski and Clonus. This is all easy stuff for everyone. Okay. Let's talk a little bit more specifically on peripheral nerve and injuries. Again, the nerve we talked about, full peripheral nerve is composed of fibers, blood vessels, and connective tissues. The large peripheral nerve is a nerve fiber. The nerve fibers are surrounded by endoneurium. Again, definition. The fibers come together to form fascicles covered by perineurium, and the peripheral nerve, the entire nerve, and often these are mixed nerves. They have sensory and motor function. Peripheral nerves are composed of fascicles surrounded by epineurium. Again, peripheral nerve anatomy, just know the definitions. Fascicles, you can have monofascicular, oligofascicular, or polyfascicular. In nerve repair, for those budding hand surgeons, obviously you can have group fascicular repair, and sometimes people advocate that for median nerve lacerations in the forearm or ulnar nerve lacerations at the wrist. You want to match up the motor fascicles as opposed to the sensory fascicles, but they're not going to be very specific on that. Now, there's 3 types of nerve fibers that they may ask you. Type A is the large, heavy myelinated, fast speed fibers, which are touch. Type B is the intermediate myelination and medium speed, seen in autonomic nervous system. Type C is their favorite one. There's no myelination, slow speed, and it's the pain fibers. Nodes of Ranvier. Conduction is facilitated by gaps between Schwann cells, and that's the nodes of Ranvier. Blood supply is extrinsic blood supply and intrinsic blood supply. These are all peripheral nerves are very vascular, so you can actually transpose one like you do an ulnar nerve transposition. You can transpose it since you have such a vascular supply. You can get away with it and not cause a vascular insult when you move it. When you have a peripheral nerve injury, Wallerian degeneration, they like that. You have death of distal axons and myelin, the loss of myelin. You get proximal axonal budding at 1 month after injury, so there's a delay in nerve repair, right? You know nerve regeneration occurs at 1 millimeter per day, according to Sedan. But when you measure the distance from the injury to the site of the, distally, you have to take into account that 1 month after injury before you get a sufficient proximal axonal budding to initiate the response. Pain is the first modality to return. Peripheral nerve injury, 3 types: neuropraxia, axonotemesis. I've never really figured out how to say these. If someone knows, you can let me know. Neurotemesis, neurotemesis. So the first one is local ischemia, selective demyelination, good prognosis. The second is more severe injury. The axon and myelin sheath are disrupted, but the endoneurium is intact, so you have some tube for the nerve axons to generate down to their appropriate effector organ. And the last one, you have complete division with the epineurium and endoneurium disrupted. The whole tube is disrupted, so you have a poor prognosis unless you fix it, and you still don't necessarily have a great prognosis, depending on the age and the level. So what's peripheral nerve recovery influenced by? Contact guidance by basal lamina and Schwann cells. Neurotrophism, factors enhancing growth. Neurotropism is attraction to the nerve tissue. Know those those 3 definitions. They shouldn't test you too much. On that, but there's a lot of research going on in peripheral nerve repair currently that's trying to manipulate a lot of these factors to enhance nerve repair. Of course, EMGs and nerve conductions are always helpful to determine extent of injury and monitor recovery for a peripheral nerve injury. What's the best results for peripheral nerve? Younger patients always do better. Several methods are available: muscular inertization, epidural repair, group fascicular repair. Now the new conduit repairs in segmental gaps of less than 2 centimeters, nerve grafting, cable grafting, sural graft is the most common choice, and then vascularized nerve repairs. There's some questions about whether epidural repair is better than group fascicular repair. They may or may, I don't think they'll ask you that level. Epidural repair is the most common, and the most recent research has, or the question they'll ask will be, is there a difference between group fascicular and epidural repair in overall functional result? And there's not. Okay, connective tissues, tendons. This is the easier stuff, getting easier. Dense, irregular arranged tissues that attach muscle to bone, composed of fibroblasts arranged in parallel. Fibroblasts produce type 1 collagen, 85%. Composed of fascicles or collagen bundles. The fascicles are separated by endotenon and surrounded by epitenon. Again, tendon histology, you have the fascicles, and then you can get down all the way to the collagen fibril, but it's a fascicle surrounded by endotenon, and then the whole tendon is surrounded by epitenon. The endotenon is on your, the tendon fascicles are on your left, and you can see how they're separated by structure, the endotenon, and then the epitenon is the thick structure on your right, on the top of the slide, and that's used for your epitendinous repair for, say, flexor tendon injuries. Tendon insertion into bone, there's a transitional tissue. It's not, the tendon just doesn't insert into bone. It's tendon, fibrocartilage, mineralized fibrocartilage, which are the Sharpie's fibers, and then bone. And be familiar with that transitional tissue format there, and it enhances force dissipation, so you're not rupturing your tendon every time you overdo it. There's two types of tendons. The peritoneal tendon, like the Achilles, it's a very vascular tendon, has a rich capillary system. Sheath tendons are the hand flexors. You have mesotendon or vinculi, which carries a vessel that supplies one segment of the tendon. And the rest of the tendon is avascular and has to get nutrition through diffusion from that vascularized segment. So as a result, peritoneals are more vascular and they're going to heal much better. And this is a great slide showing you how vascular a peritoneal, this Achilles tendon, is. But if you look at a sheath tendon, like a flexor, hand flexor, you can see it has a very limited area of high level of vascularity, and the rest is relatively avascular. The few things you need to know about tendon healing: it's initiated by fibroblasts and macrophages. Tendon repair is weakest at 7 to 10 days. Maximum strength is at 6 months. Mobilization increases strength of tendon repair, but in the hand, obviously, it can be a detriment because you get a lot of adhesions and lose motion. So the key is having a strong enough tendon repair that allows early or relatively early motion to prevent adhesions. Ligaments, type 1 collagen, 70%. So tendons were 85% type 1 collagen, ligaments are less so. They stabilize joints. They're similar structures to tendons, but they're more elastic, and they have less collagen content. They have more elastin content. They have uniform microvascularity from the insertion site, so they tend to heal better than tendons. They also have mechanoreceptors and nerve endings, so they can be painful when you rupture a ligament. There's two types of ligament insertions into bone, which you need to be familiar with. One is an indirect insertion, which is the most common type. Superficial fibers insert at acute angles into the periosteum. P is the periosteum. It's just a acute insertion directly into the periosteum. The other insertion is direct insertion, and this is similar to the tendon insertion. It goes through several tissue transition phases. You have ligament, fibrocartilage, mineral fibrocartilage, and bone, and you can kind of see that in the histology where B is bone and L is ligament, and you have a sort of a fibrocartilage interface between the two. This is less common, the less common insertion type. Ligament healing is improved with normal stress and strain across the joint. That's why when you do your ACLs, you want to get them moving early. Early ligament healing, this is important. You have type 3 collagen for early ligament healing, and this is converted to type 1. So immobilization decreases the elastic modulus. So moving early is important. Ligament injury, the most common mechanism is rupture of sequential series of collagen fiber bundles. In adults, they tend to get mid-substance tears. In kids, you tend to get avulsion injuries. And when you do have an avulsion injury of a ligament in a child, it occurs between the unmineralized and mineralized fibrocartilage layer of the direct insertion site. Okay? Discs, two components. Central nucleus pulposus has a high amount of glycosaminoglycans and low collagen, and it's mainly type 2 collagen, as opposed to the annulus fibrosus, which is a very high collagen content, mainly type 1 collagen. The annulus has high tensile strength, and it has nerve fibers present. That's why it hurts when you herniate a disc through the annulus. Okay? And the majority of the discs it's 85% water. Here's an EM showing the annulus on the left, which is type 1. You see how it's very well organized compared to the nucleus pulposus, which is type 2 collagen and much less organized. Aging disc question, you have a decrease in water content and proteoglycan content. You have less proteoglycan, it results in less retention of water. You have increased collagen diameter and keratin sulfate concentration. I know Dr. Lauerman might have talked more on this. Cigarette smoking is a risk factor for degenerative disc disease. I just thought this was an amusing picture. But, all right. Let off some steam. All right. Test questions. Okay, guys. Healing after complete mid-substance laceration of skeletal muscle in adult is characterized by which one? Dense scar tissue, right? You never get normal muscle. Osteoporosis in a 4-year-old female marathon runner is commonly associated with, easy question, amenorrhea. Which of the following is considered a serious and possibly irreversible side effect of anabolic steroid use? I mean, there's only one that looks irreversible, right? Growth retardation. So, what muscle action is defined by muscle activation with simultaneous muscle lengthening? What is it? Eccentric. Type 1 skeletal muscle fibers are characterized by, remember, slow red ox, right? So which answer? A, B, C, D, or E? B? Right? They're seen in endurance athletes. They don't have a lot of force. The sprinters, type 2 fibers have the high contraction rate. What is characteristically seen in fast glycolytic type 2B fibers? So low strength, high fatigue resistance, high aerobic capacity, high anaerobic capacity, or small motor unit? High anaerobic capacity, right? To maximize the potential for functional recovery of a nerve cut during surgical repair, to maximize the potential for functional recovery of a cut nerve during surgical repair, it is of utmost importance to, this I'm sure everyone knows, you got to properly align the nerve ends to try to get the fascicles oriented properly so that the proximal axons can make it to the effector organ distally. A woman sustains a grade 2 partial tear of the hamstring muscle during a sudden stretch while sprinting. The tear usually occurs at the myotendinous junction. Which of the following is considered the primary factor resulting in a decreased ability of the intervertebral disc to maintain a high water concentration? As the disc ages, you end up getting a loss of your proteoglycan aggregates. What is the major constituent by wet weight of intervertebral disc in a 20-year-old patient? We went over that, right? Water. All right. After you take, are you guys taking your boards in that same hotel in the Hyatt in Chicago, right? There's a bar there called it's the world's longest bar or something like that. It's the most happening place right at about 5 o'clock the day you're boards. You won't end up leaving there for a long time. But that's about how big the beers are there. All right, welcome to hell, guys. Are there any engineers in here? You probably already know all this, so. Now, I want to try to make this as simple as possible. They're not going to go crazy with the biomechanics section of the test. All right? I hope I can make it as simple as Einstein did. Put your hand on a hot stove for a minute, it seems like an hour. Sit with a pretty girl for an hour, it seems like a minute. That's relativity. Maybe I'll make it, I hope to make biomechanics as easy as that to understand. It's going to be a little difficult, but let's kind of go through this. You have to know SI units, derived quantities. You just need to know definitions. If you know the definitions in the biomechanics and biomaterials section, you'll get majority of the questions right. You really don't have to apply a lot of what you know. You just have to know the definitions. All right? I shouldn't say that up here, but that's the truth. So what's velocity? Meters per second, rate of change of displacement. Acceleration is meters per second square. It's the rate of change of velocity. Force, kilogram meters per second square, action of one body on another. Okay, that's Newton's laws. You have to be familiar with it. First law, inertia, sum of external forces applied to a body is 0. That's important for a free body analysis. We'll talk about that shortly. Second law, acceleration is directly proportional to the force applied to an object. That's involved for dynamic analysis. And the third law, for every action, there's an equal and opposite reaction. It's involved for free body analysis. Okay, let's just be kind of familiar with that stuff. Know the difference between scalar and vector quantities. Scalar quantities have a magnitude but no direction. So they're volume, time, mass, and speed. Vector quantities have magnitude and direction. So they're force, velocity. Vectors can be added, subtracted, and split into components, and they're important for some of these questions they ask you. For free body analysis, you have a resultant force, which is a single force equivalent to a system of forces acting on a body. So in this case, the resultant force is the force from the ground up across the hinge of the seesaw. The equilibrium force of equal magnitude and opposite to the resultant force. So You have the two bodies, you have a moment arm, we'll talk about this, and then you have a resultant force so that the forces are in equilibrium. They negate each other. They're equal to zero. And that's what's important for free body analysis. You have to know what a moment is. It's the moment, a moment is a rotational effect of a force on a body at a point. So, when you're using a wrench, a moment is the torque of that wrench, and it's defined by the force applied and the distance or the moment arm from the site of action. So that's what you need to be familiar with a moment arm, and we'll talk about that shortly. A definition, mass moment of inertia, is a resistance to rotation. You have to overcome the mass moment of inertia before you actually have an effect. Free body diagrams. You just have to get a basic idea how to answer these. I didn't have one on my boards 2 years ago, but that doesn't mean they won't show up. They're all forces acting on a body. The weight of the objects act through the center of gravity. In the human body, the center of gravity is anterior to S2. In this particular picture, the center of gravity is S2. Now, if you're holding a weight out away from your body, the effect of the weight is going to be the weight plus the distance from the center of gravity. That's the moment arm, okay? So you have that. Now, what's counteracting that keep you from toppling over is that your extensor muscles of the spine are acting and keeping you upright. And that is equivalent to that force plus the moment arm from the center of gravity. And all of this is zero. In equilibrium, all of this is zero. So the key to these free body diagrams is that you determine the force from one object, determine the force from the opposite object, and you're going to have an unknown that they're going to ask you to solve for. And if you equate it to zero, you'll be able to figure it out. So how do we do it? You have a diagram, know the concept of equilibrium, Newton's laws. You identify the system, objects known, and assumptions. Select a coordinate system. Look at the free body diagram, apply Newton's laws, and solve for unknowns. Now, you need to understand this, but this is a very low-yield thing, because chances are you may get one question on this, and some people just punt it. But they're usually pretty easy. Okay, they don't make it complicated because they don't need to make it complicated. If you find yourself spending 2 hours looking at one of these questions, you're missing something. Okay, one of the more common ones is they show this hip, right? And they show a patient standing on the right hip. Okay? They want to know what's the abductor force of the right hip, FAB in this diagram. Okay? So why is it the center of gravity is S2 again? So if you're standing on your right hip, you have to assume that they want to know, again, the abductor force that's keeping you from rotating, keeping you on that right hip. So you're going to have your center of gravity and your weight in one direction. And it's 5/6W because you're making an assumption that your right leg is 1/6 of your weight. Okay, so that's 5/6W. And that's acting. They want to know the forces around zero, which is a joint. Okay? And they want to know, so B is the moment arm from that center of rotation. So 5/6W times B is going to have to equal the abductor force times the moment arm for the abductors A. And if you're in equilibrium, which means you're actually able to stand on your right hip and you're not going to topple over, they have to equal each other. So they want you to find FAB. So they give you B as 15 centimeters. They give you A, right? A times FAB, which is 5 centimeters. And they give you, the 5/6 of your body weight. So the only unknown is FAB. And now you can solve for that, okay? They may ask you, they'll never ask you the joint reactive, they want the joint reactive force, FJ. That involves calculating cosines, sines. If you're doing that, you shouldn't be doing orthopedics. All right? So you need to know the basics. Moment arm, force, equilibrium. There's going to be one unknown, equal them to each other, and solve for the unknown. That's as difficult as these questions are going to get. Other definitions you need to know. Work is a force acting on a body to cause displacement. It's measured in joules. Energy is the ability to perform work. Law of conservation. Energy is neither created nor destroyed. It's transferred from one condition to another. And that's important in fractures. When you have high velocity injuries, you get really comminuted fractures because energy is not lost in the system. It's conserved, but it's transferred to the bone, and that's why the bone is 100,000 pieces when you have a high energy injury. Potential energy is stored energy. It's the ability of a body to do work as a result of position. And kinetic energy, which is again important in fractures, is the energy of the object due to motion. And everyone remembers kinetic energy is 1/2 mv squared. Friction is the resistance between two bodies when one slides over the other. The applied force has to be greater than friction before you can get motion. It's all common sense there. Let's talk a little bit about biomaterials. Again, definitions will save you. What's stress? It's the intensity of internal force. It's determined by force over area. It's the internal resistance of a body to a load. So you're going to apply a load, and the force, internal force that generates to counteract that load is the stress. And it's determined by force over area, and it's pascals is the unit. It's newtons over meters squared. Strain is the measure of deformation of a body as a result of loading. Strain is a proportion. It's the you load an object, it changes in length under that load. So the change in that length over the original length is the strain. And it has no units. That's been a question, actually. Which of these components has no units? Stress or strain, and strain is the answer. Know this, at least until after your board. Stress-strain curve. Okay? Everyone is familiar with this. Stress and strain. What's Young's modulus of elasticity? It's stress over strain in the elastic portion of this curve, meaning up to, is this showing up here, guys? Yeah. Up to this point, which is the proportional limit. After that, you get plastic deformation, and it's no longer proportional. Now, let's go to these definitions. Again, definitions will save you. The yield point, or the proportional limit, is the transition point from the elastic, which is the linear portion of this curve. So if you're within that linear proportion and you apply a load, once you reduce that load, it's going to return to its normal shape, right? But once you get past that, you get into the plastic portion of it, and that's the yield point. The ultimate strength is the maximum of strength obtained by a material before it reaches its breaking point. Breaking point is the point where the material fractures. Plastic deformation is change in length after removing the load in the plastic range. You don't get return to its normal shape. The strain energy is the capacity of a material to absorb energy. It's the area under the stress-strain curve. Again, definitions, they're really not going to ask you to apply this. I just want you to know what they mean. Hooke's law, stress is proportional to strain up to the proportional limit. So that means anytime you're along that, it's a proportion, and if you go beyond that into the plastic area, then it's no longer proportional. Young's modulus of elasticity is the favorite question. It's the one you need to know. It's a measure of stiffness of a material. It is a material property, not a structural property. Structural property is rigidity, and we'll talk about that in just a moment. But stress over strain is a measure of stiffness in the elastic zone. Okay? Let's talk a little bit about material properties. Materials are defined by their mechanical properties, their force, stress, strain, elasticity, plasticity, viscosity, and strength. So let's talk specifically about a few materials. Brittle materials such as PMMA, they exhibit a linear stress-strain curve up to a point of failure. When they fail, they fail. There's no recoverable elastic deformation. They have fully recoverable elastic deformation prior to failure. They don't undergo a plastic deformation phase. So they'll deform to a point, and when they deform, then they'll fail. Okay, so there's no plastic area under the curve for a brittle material. A ductile material is different, such as metal, where you have a large amount of plastic deformation prior to failure, and ductility is defined as post-yield deformation. So metal will deform before it fails completely. So undergo plastic deformation. What's visco-elasticity? That's seen in bone and ligaments. Again, definitions. It exhibits stress-strain behavior that is time-dependent. Materials deformation depends on load and rate of application. That's what viscoelasticity is defined as. Isotropic materials possess the same mechanical properties in all directions. Bone is not an isotropic material. It's an anisotropic material. And that means its mechanical properties vary with the orientation of loading. Depending on how you load it, depends on its material property. Structural properties, this is different than what we just talked about. The structural properties not only take into account the material, but the shape of the object and its loading characteristics. So while you have a stress-strain curve, which is a material property, you have a load deformation curve. So it's taking into account the loading characteristics and the shape of the object. So the slope of the load deformation curve is rigidity. That's a structural property. The slope of the stress-strain curve is stiffness. That's a material property. That's about all you need to know for this part. Okay? Know the definition. These are important formulas. The bending rigidity of a rectangular structure is to the third power. The bending rigidity of a cylinder structure is to the radius to the fourth power. The area moment of inertia is resistance to bending, and the polar moment of inertia is resistance to torsion. Definitions. What's fatigue failure? Metals that undergo fatigue failure. They occur with repetitive loading cycles below the ultimate tensile strength. If the stress is constantly below this endurance limit, the material will never fail. Okay? If the stress is less than that point of failure, it can be loaded an infinite number of times without failing. The problem is if you get into above the endurance limit, then you are going to end up with a fatigue failure situation. What's creep or cold flow? Progressive deformation of metals or other materials in response to a constant applied force over an extended period of time. So you apply a force, and then you get a deformation of that slowly over a period of time, and what happens is by deforming it reduces the overall effect of the force. It can produce permanent deformity and affect mechanical function with some of these polys that experience creep. Corrosion. Again, definitions. What is corrosion? Chemical dissolving of metals in high saline environment of the body. You have galvanic corrosion, which occurs between dissimilar metals, and you get electrochemical destruction. That's why you never put titanium screws in with a stainless steel plate. You can get crevice corrosion. It occurs in fatigue cracks with low oxygen tension. Stress corrosion occurs in areas of high stress gradients, and fretting is from small movements abrading an outside layer. So corrosion, just some key facts. Stainless steel is the most likely metal to experience crevice corrosion. Stainless steel and cobalt chrome have the highest risk of galvanic corrosion. Corrosion can be reduced by using similar metals for screws and plates, or with a technique called passivation, where you coat the metal with a thin layer that separates metal from the solution. A lot of this corrosion occurs in the body because of the metal's exposure to the solutions that our body creates, the environment. Now, the most commonly used orthopedic implants, everyone knows stainless steel, which is an iron, chromium, and nickel alloy. You have cobalt, chromium, and molybdenum alloy, and titanium alloy. The problems associated with implants, I know have been discussed in the arthroplasty section. When you have a very rigid implant or a high Young's modulus of elasticity, you get a lot of stress shielding, correct? We have problems that are being looked at, ion release from some of the metals. Do they cause cancer? Do they cause a malignancy? This wear debris, we don't know. But they are higher levels of cobalt, chrome, and titanium in the blood supply of some experimental animals, and there's a question of whether is this going to be a long-term effect. We don't know. Cobalt chrome generates less metal debris than titanium. I know Dr. McPherson talked about that. So titanium has poor resistance to wear. Passivation improves the fatigue properties. It is the most biocompatible of the metals. It has a Young's modulus that is less stiff, so when you have a less stiff implant, you have less stress shielding because you actually load the femur or bone around the implant as well, and it maintains some of the bone structure, so there's less shielding of that by a very rigid, as you see with a rigid implant. Titanium is extremely biocompatible. The key thing to know about titanium, which shows up on the test, is it rapidly forms an adherent oxide coating called self-passivation. Non-metals we need to be familiar with, polyethylene. It's ductile, resilient, it's tough, it has low friction. It's viscoelastic, it's susceptible to abrasion, it's altered by high temperatures or radiation, as I know was discussed in your previous lecture. Polys, wear damage is caused by third body inclusions. There's a histiocytic osteolytic response. Wear is increased with thinner polys of less than 6 millimeters. Polyethylene wear debris is a main factor affecting longevity of total joints. Things you need to know about PMMA from a biomechanics standpoint. It reaches its ultimate strength in 24 hours, so it's not completely hard, just a few minutes after you insert it. It's strong in compression. It's poor in tension. It has a very low modulus of elasticity. I know you already know that the different generation techniques of cementing, reduction in porosity increases PMMA strength and decreases cracking. It mechanically interlocks with bone. It's not an adhesive. It's more of a grout. Wear particles can incite a macrophage response. Again, insertion can lead to a precipitous drop in a blood pressure because of an anaphylactic reaction to the monomer. If those of you have been involved with that, it is a very scary situation. Cement failure occurs from microfracture and fragmentation. Silicones used more frequently in hand surgery, less so nowadays. It's a polymer used in non-weight-bearing joints, particularly MCP and PIP joints of the hand. There's poor strength and wear capabilities, frequent fractures. The particles cause a very aggressive synovitis. There's now better implants available, particularly things like pyrocarbonate. Ceramics, again, touched on in the total joint lecture. It's metallic and non-metallic elements bonded ionically. So it's an ionic bond. That's been on the test as well on the previous question. It's an ionic bond in a highly oxidized state. Alumina is an example. It's very brittle, but it has the highest elastic modulus. So it's very stiff, but when it breaks, it breaks. There's no area of plastic deformation before it breaks. Low resistance to fracture, but it's very good in compression. So ceramics have better characteristics than polys. They have a low oxidation rate, less friction. They produce less particles, and they have diminished wear. You've seen this chart already in the previous lecture, but commit this to memory for the test, because there will be a question on which list the following in the increasing order of Young's modulus of elasticity. And ceramics are the highest, cartilage is the lowest, chromium, cobalt chrome, steel, titanium. You see, titanium is close to cortical bone, and that's why you don't get as much stress shielding, because it's similar, it has a similar elastic modulus as cortical bone. Some of the unique characteristics of biomaterials: they're viscoelastic, they undergo creep, and they have the ability for self-adaptation and repair. Let's talk specifically about our favorite, bone. Mechanical properties. The collagen has low stiffness, but it has excellent tensile strength and poor compressive strength. But the hydroxyapatite portion of bone is stiff, has a very high Young's modulus. It's brittle, and it's good in compression. Bone is anisotropic and viscoelastic. That's another question for you. And it's strongest in compression and weakest in shear. Biomechanics of fracture: when you have a tension force, you get a transverse fracture. When you have a compression force, you get more of a crush fracture. Shear type fractures are seen around the joints. When you have a bending force to a bone, there's a fracture on the tension side, and the butterfly fragment is on the compression side. It's another question, potential question. Torsion causes a spiral fracture, and when you have a torsional force, the greatest stress is at the outer periosteal surface. Let's talk a few minutes about metal implants. Screws. Definitions you need to know. Pitch is the distance between threads. Lead is the distance advanced in one revolution. The root inner diameter is important for tensile strength, and the outer diameter is important for pull-out strength. So, again, screw, you look at the pitch, the lead, the outer diameter, and the root diameter. Most importantly, when you're putting these screws in, you want to maximize pull-out strength. So this could potentially be a question right here. How do you maximize pull-out strength of a screw? You make sure they have a large outer diameter, a small root diameter, and a fine pitch. Plates. Strength is based on the material used and the moment of inertia. Again, we talked about the bending rigidity of a plate is proportional to its thickness, so it's T to the third. So, and plates are most effective on the tension side of a fracture. They are load-bearing devices, so if you double the thickness of a plate, you're going to increase its rigidity by 8, right? 2 to the third. Intermedullary nails have a high polar moment of inertia. The bending rigidity is proportional to the radius to the fourth. It's a load-sharing device. It provides torsional and bending rigidity. It's better at resisting bending forces. Hoop stresses are lowest for slotted titanium nails. That's been, I don't know, hoop stresses is a favorite topic, but I don't think it's that important. But that has been a question in the past, that the best nail to eliminate hoop stresses when you're inserting a femoral nail is a slotted titanium nail. External fixators. Stability of fixation is maximized by these following things. They love external fixator questions. How do you maximize stability? You bring the fractures together. That's the most important. You can increase the diameter of the pins. You can add more pins. You can decrease the bone to rod distance. You can put pins in different planes. You can stack the rods in different planes. And you can do the near, far, far pin placement. Those all increase the stability of fixation of an external fixator. Last section, guys. Almost done. All right, so joint biomechanics. A few things to know. The joints have 6 degrees of freedom. Joint reaction force they want you to know the definition of a joint reaction force. It's the force generated within a joint in response to an external force. Muscle contractions are the major contributions to joint reaction force. And that's a favorite question. What affects joint reaction force the most? Muscle contraction. Instant center of rotation around the joint is difficult to determine. It's frequently changing depending on the position of the joint. But the majority of the time, there is a most common center of rotation, and that's the point at where the joint rotates. And we'll discuss that in just a minute. A few things to know about joint biomechanics. Friction, again, definition, resistance between two bodies. Lubrication decreases the coefficient of friction. The coefficient of friction, and this was touched on in the total joint lecture, human joints that's the coefficient of friction. Look at a metal and poly, it's a factor of 10 higher. So even the best we have isn't anywhere near the decreased friction in a normal human joint. This has been a question before, and Dr. Foster will touch on this, but elastohydrodynamic lubrication is the primary lubrication of a human articular joint, cartilage. Hip biomechanics. They love range of motion questions, and they like where do you position a joint for arthrodesis? Those pop up frequently. So the hip functional range of motion is listed. Joint reaction force varies from 3 to 6 times body weight. Joint reaction force is due to contraction of muscle across the joint. A cane in the contralateral hand reduces joint reaction force up to 60%. A Trendelenburg gait reduces your joint reaction force by reducing the abductor moment. Now, what did we decide a joint reaction force was? Now, if you look at your abductors, it's the force of the abductors plus the moment arm, okay? So in a Trendelenburg gait, someone is shifting their body weight over their joint. So if they're shifting the center of gravity over their joint, what's happening to the moment arm? It's getting smaller, right? Because the center of gravity is usually S2. If you're moving your center of gravity over the joint, the moment arm is getting smaller. So the moment arm times the force of the abductors is going to be less. And that will cause less joint reactive force. Same thing with a cane. A cane helps because when you use a cane, you're shifting your body when you're using the cane, and you're reducing your moment arm, and that reduces your joint reactive force, and that's why it's less painful. Hip arthrodesis. Positions vary, but this is a general guideline. 25 to 30 degrees of flexion, 0 degrees of abduction, and neutral rotation. Knee biomechanics, here's your average range of motion, average degrees for squatting. I'm not going to touch much on this, but posterior rollback of the femur on the tibia increases maximum knee flexion. And I'll let the joint guys talk more about that. Knee biomechanics, look, just a general idea. When you're walking for the ACL, look at the peak load. When you're running, 500 newtons. But the ultimate strength is 1750 newtons. So when you have an injury, it's pretty big. It's a pretty high force along the ACL to cause that injury. Look at the patellofemoral joint. That is the highest force, 7 times body weight when you're running. That's why people tend to have patellofemoral symptoms when they do long-distance runnings. Look at that amount of body weight compared to climbing, climbing stairs or even walking at the patellofemoral joint. Knee arthrodesis, 0 to 7 degrees of valgus, 10 to 15 degrees of flexion. Ankle and foot biomechanics. The center of rotation is the talus. Average range of motion is listed. Arthrodesis position of the ankle, 0 degrees of dorsiflexion, 5 to 10 degrees of external rotation, 5 degrees of valgus. You don't want to put them in varus. And there's the foot forces that it experienced, 3 times body weight with running, which is still less than what the patella experiences. So the patellofemoral joint seems to experience the highest rate of force when running. Spine, motion segment is 2 vertebra and an intervening soft tissue. In the intervening soft tissue, there's 6 degrees of motion again. Center of gravity is anterior to S2. The disc is visco-elastic and demonstrates creep. Remember, the bone and our disc, all of these are unique characteristics, biomaterial characteristics of components of the body. They demonstrate viscoelasticity and creep. Disc pressure, look at these numbers. It's lowest, again, when you're in a supine position. It's lowest when a load is carried close to the body. Why is it low when it's carried close to the body? Because your moment arm is small. If you put the load out here, your moment arm is huge, and your joint reaction force is going to be enormous with a given amount of weight. So fatigue fractures, fatigue loading causes pars fractures, compression fractures are seen in the end planes. Osteoporosis, again, we talked on this, loss of horizontal trabeculi with resultant loading, with resultant loss of vertebral stiffness. Shoulder biomechanics, another favorite question. Glenohumeral motion is 120 degrees, scapulothoracic is 60. It's a 2-to-1 ratio. We'll let Dr. Miller touch on this, the sports guys touch on this, but stability the shoulder has limited bony stability. Inferior glenohumeral ligament is important static stabilizer. Rotator cuff is the dynamic stabilizer of the shoulder. They liked some of these throwing questions and these are just factoids to remember. Stress on the posterior capsule is highest in the follow-through phase of throwing. Deceleration is the most violent phase of pitching, and the rotator cuff is the principal decelerator, so it's most susceptible to injury. Shoulder arthrodesis position, 30 degrees of abduction, 20 degrees of forward flexion, 40 degrees of internal rotation. Elbow biomechanics, center of rotation is the trochlea. Functional range of motion, 30 to 130, 50-50 pronation, supination. Stability, the major stabilizer for valgus load is the anterior band of the medial collateral ligament. Radial head is the secondary stabilizer. LCL, ankyneus, capsule provide lateral stability. Another throwing, pitching question, valgus extension overload occurs during late cocking and early acceleration phases of throwing, and it can cause chronic medial instability. Elbow arthrodesis position. If you're doing a unilateral arthrodesis, 90 degrees of flexion. If you're going to do bilateral, which I hope none of you have ever seen, I sure haven't, but one elbow at 110 degrees for eating and the other at 65 degrees of flexion for other care. Wrist biomechanics. Instant center of motion is the head of the capitate. Normal range of motion is listed. A question that's come up is the flexion extension arc. 2/3 of it is the radiocarpal joint. 1/3 of it is the midcarpal or intercarpal joint. The distal radius sees 80% of the load across the DRUJ. The distal ulna sees 20% of the load of the DRUJ. Wrist arthrodesis position, 10 to 20 degrees of extension if you're doing it unilaterally. In cases you have to do it bilaterally, you want 10 to 20 degrees of extension and 10 to 20 degrees of, on one side, 0 to 10 degrees of flexion on the other. That was on my OIT, my chief year, which I missed. Hand biomechanics. Normal range of motion is listed. And remember, MCP collateral ligaments, they're taut in flexion, they're lax in extension. That's why you want to put people in intrinsic plus position to prevent problems with contractures. This is unlikely to show up, but positions of hand arthrodesis, so I wouldn't waste too much of your brain space for that. Now, Education is what remains after one has forgotten everything you learned in school. You're going to forget all this stuff. Just keep it around long enough for the exam, and you'll do just fine. So we have a few things to go over, and then we'll finish. This is the questions that the level of detail of questions that they expect you to know for the biomechanics section. Okay? In the analysis of mechanical forces, a moment is caused by A, B, C, D, or E. D, right? Force acting at a distance from a point. A lot of these are just definitions, and the definitions can save you. The linear relationship between an applied stress and the resultant deformation defines a material's A, right? Modulus of elasticity. Mass moment of inertia is defined as the resistance to, this is a mechanical property, it's to rotation, similar to the polar moment of inertia. Which of the following is the major contributory factor to joint contact force? Which one is it? The last one, right? Muscle contraction about the joint. In total hip replacement, moving the abductor attachment away from the joint center will do which of the following? This was touched on in joint lecture. What does it do? Increase the abductor moment arm. Perfect. You guys are all over it. 3 months following total hip replacement, a patient has persistent marked Trendelenburg gait. Compared to normal conditions, this results in which of the following biomechanical consequences? A, B, C, D, or E? Right? Because you're reducing your moment arm. A person will become more fatigued when holding a weight at arm's length from the chest rather than close to the chest, primarily because, again, they love this question. The moments of the weight and the arm around the spine are increased if you hold it out. For some reason, your arm also your arm weighs something, so that adds to the force, joint reactive force, if you're holding it out here as opposed to holding it close to your body. Which of the following is characteristic of a viscoelastic material? Deforms depending on load and rate of application, right? Which of the following will help prevent corrosion of an implant? Say something, guys. Right. Oxide layer. A material that has the same mechanical properties in all directions is referred to as isotropic. The deformation of a material with respect to its original shape as a result of an applied load is referred to as, which one? Strain, right? So it's a change in its shape over its original shape. The resistance of a structure to deformation from an applied load is called stiffness, right? Which one is this? The following materials, PMMA, stainless steel, and titanium, cortical bone, list them in increasing elastic modulus of stiffness. So what's the least stiff? And the next? Bone, right. So PMMA, bone, titanium, and stainless steel. Doubling the thickness of a metal plate will have which of the following results on its mechanical properties? Bending, right. Stiffness of external fixation systems for small bones is increased when? Which one? Pin length? No. Threaded pins? They're all, most of them, seem to be threaded. Fewer than 4 pins. Pins are placed further from the fracture. No. So, it's easy. Pin diameter is increased. Large amount of comminution and soft tissue damage associated with a fracture reflects, again, kinetic energy imparted to the bone was large. Cortical bone exhibits its greatest strength when subjected to compression. Most biologic materials are anisotropic, meaning that their stress-strain curve exhibits A, B, C, D, or E. Definitions guide, right? Direction of load application. What is the most likely mode of failure seen in fracture fixation device about which a non-union of bone has developed? Fatigue, loading. All right, fatigue, fracture of the plate. When a long bone is subjected to a bending moment, the greatest tensile stresses are located where? C, right? At the periosteal surface.